cycle and menstrual cycle abnormalities. Benign breast conditions. Vulvovaginitis. Vulvovaginitis in pediatric patients. 1b polycystic ovary syndrome. Pelvic inflammatory disease. A equals A9 home library list settings. X cervicities. Cervicities is the inflammation of the cervix. Cervicities is most commonly caused by infection, example with chlamydia trachomatis or Neisseria gonorrhoeae. Non-infectious causes include cervical dysplasia and mechanical or chemical irritation. Patients are often asymptomatic but may present with vaginal discharge, abnormal vaginal bleeding, dyspareunia, or pelvic pain. Cervicities is a clinical diagnosis, based on gynecologic examination findings of mucopurulent or purulent endocervical discharge and a friable cervix. In isolated cervicities, clinical features of pelvic inflammatory disease, PID, and diagnostic criteria for PID are absent. Initial diagnostic studies include evaluation for STIs. Treatment consists of empiric antibiotic therapy for individuals with risk factors for STIs. Individuals without risk factors for STLS are treated with antibiotics if diagnostic testing confirms an infectious cause. Patients with no evidence of infection should be referred to gynecology for further evaluation. Untreated cervicities can lead to PID, in which the infection spreads beyond the cervix to the upper female reproductive tract, i.e., the uterus, fallopian tubes, and ovaries, and/or peritoneal cavity. Why and etiology. Scent infectious, most common C. trachomatis, and gonorrhoeae, HSV2CJ, Trichomonas vaginalis I, plus non-infectious LTT. Copyright mechanical irritation, example cervical caps, diaphragms, tampons. Copyright chemical irritation, example contraceptive creams, latex exposure. Copyright cervical dysplasia or polyps. Risk factors. 1. Young age. WI. CE. Clinical features. Cervicities is often asymptomatic. Clinical features may include 3. Vaginal discharge, may be purulent, blood-tinged, and/or malodorous. Scent. Postcoital or intermenstrual bleeding. Dyspareunia. Lower abdominal or pelvic pain. 1. Symptoms of the underlying condition, example genital lesions in HSV infections. Fever is not a typical symptom of cervicities. Presence of fever should raise suspicion for PID. WA. RON. Diagnostics. Clinical evaluation. 1. Isolated cervicities is diagnosed clinically, based on both of the following. Presence of one of the following findings on speculum examination: O mucopurulent or purulent discharge in the endocervical canal or on an endocervical swab. MO erythematous, edematous, friable cervix. Scent. Absence of both. Copyright clinical features of PID. Copyright diagnostic criteria for PID, example cervical motion tenderness, on bimanual pelvic exam. Abdominal tenderness and cervical motion tenderness are not characteristic of isolated cervicities and suggest that infection has ascended, causing concomitant PID. AA. Collapse. Fine text outline. X cervicities. Clinical evaluation. Isolated cervicities is diagnosed clinically, based on both of the following. Scent. Presence of 1 of the following findings on speculum examination. Copyright mucopurulent or purulent discharge in the endocervical canal or on an endocervical swab. AO erythematous, edematous, friable cervix. Absence of both. Copyright clinical features of PID. Copyright diagnostic criteria for PID, example cervical motion tenderness, on bimanual pelvic exam. Abdominal tenderness and cervical motion tenderness are not characteristic of isolated cervicities and suggest that infection has ascended, causing concomitant PID. Laboratory studies. 1. Scent. Vaginal or cervical swab testing. Copyright NAAT for N. gonorrhoeae and C. trachomatis. O. Wet mount preparation to evaluate for WBCs, leukorrhea, Trichomoniasis bacterial vaginosis. Copyright if wet mount is negative for trichomoniasis, obtain NAAT or culture for trichomoniasis. Scent test all patients with cervicides for HIV and syphilis. At, cervicides is unlikely if. 4. Treatment. If presentation is concerning for PID, provide treatment for PID. Scent treat with empiric antibiotic therapy for cervicides if, copyright patient has risk factors for STIs or there is concern for poor follow-up. ENAAT testing could not be done. Scent all other patients, consider waiting for diagnostic test results. Copyright if positive, treat with appropriate therapy based on the causative agent. Copyright if negative, evaluation for non-infectious causes. Scent for patients' sexual partners from the preceding 60 days, recommend, copyright STI testing or presumptive treatment for chlamydia, gonorrhea, and/or trichomoniasis based on patient's test results. Advise abstinence from sexual intercourse until patient and partner have completed treatment and are asymptomatic. After completion of treatment, follow up to evaluate for symptom resolution. Empiric antibiotic therapy for cervicides. Scent doxycycline, preferred, or azithromycin, alternative. Scent consider empiric coverage for N-gonorrhoea with ceftriaxone based on community prevalence and patient risk factors. 7 CE. Complications. Pathogens that cause cervicides can ascend to the upper female reproductive tract and result in PID. We list the most important complications. The selection is not exhaustive. QL. Collapse. Find text outline. Urocervicides, 1/1. Vaginal discharge in gonococcal infection VV. Purulent discharge can be seen on this patient's vulva on external genital examination. Source, Soagonoro female by SOAIDS Amsterdam, Wikimedia Commons, licensed under CC by SA 3.0. Urocervicides, 1/1. Infectious cervicides. Colposcope view of the ectocervix in a patient with chlamydia trachomatis. The ectocervix is erythematous and there is purulent discharge coming out the external OS. Source, Chlamydia trachomatis female by Gerard M., Wikimedia Commons, licensed under CC by SA 3.0. X. The menstrual cycle and menstrual cycle abnormalities. The menstrual cycle is a highly regulated physiological process that makes conception and pregnancy possible. From the start of menstruation, menarche, to its cessation, menopause, menstrual bleeding, menses, is regulated by hypothalamic and pituitary hormones. Even the smallest changes in hormone levels can result in menstrual cycle abnormalities. Hormonal changes are not necessarily pathological, they can be caused by a variety of conditions and factors, example medication, stress. Abnormal menstrual patterns are identified based on changes in the frequency, intensity, and onset of bleeding. Common manifestations of menstrual cycle abnormalities include amenorrhea, menstrual cessation, dysmenorrhea, painful menstruation, and abnormal uterine bleeding, AUB, example increased frequency and/or volume of menstruation. Discomfort prior to the onset of menstruation that is accompanied by psychiatric, gastrointestinal, and/or neurological symptoms is referred to as premenstrual syndrome, PMS. WA. OE. Physiology of the menstrual cycle. Hormonal feedback loops. The menstrual cycle is a tightly regulated process in which the coordinated release of hormones from the hypothalamus, pituitary gland, and gonads produces a single mature oocyte. These hormones are controlled by positive and negative feedback loops. Scent follicular phase. Copyright the hypothalamus releases gonadotropin-releasing hormone, GnRH, in pulses, stimulating the anterior pituitary gland to release follicle-stimulating hormone, FSH, and luteinizing hormone, LH. Equals FSH and LH stimulate the ovaries. Equals in the ovarian follicle, the theca cells and granulosa cells are in charge of hormone production. OLH stimulates theca cells and induces the production of progesterone and androstenedione. OFSH stimulates granulosa cells and recruits a group of maturing follicles in the ovary production of estradiol and inhibin B in the growing follicles. Negative feedback to the pituitary gland inhibited FSH release. The day before the LH levels rise, one follicle becomes dominant, the remaining follicles regress as FSH levels decrease, and estradiol levels peak. Positive feedback to the pituitary gland. LH levels increase rapidly. Ovulation. LH surge induces ovulation. The mature oocyte is released from the dominant follicle and the corpus luteum produces progesterone. LH inhibition. Luteal phase. Falling LH levels cause degeneration of the corpus luteum, decreased progesterone and estradiol levels. The endometrium cannot be maintained. Menstruation occurs. The hormonal feedback loop is also influenced by other hormones, example prolactin, and neurotransmitters, example opioids, acetylcholine, noradrenaline. The feedback mechanisms are controlled by upregulating or downregulating hormone production as needed. Menstrual cycle 2-1. A normal menstrual cycle lasts 24 to 38 days, 28 days on average, with the first day of menstrual bleeding counted as day 1 of the cycle. I3E menses lasts an average of 3 to 7 days, with an average blood loss of 35 to 50 ml. The menstrual cycle involves simultaneous changes in the ovaries, ovarian cycle, and the uterus, uterine cycle. The cycles relate to one another. Copyright ovarian changes are regulated by hormones released from the anterior pituitary gland. Uterine cycle changes are regulated by hormones released from the ovary during the ovarian cycle. Low estradiol levels keep FSH and LH levels low, leading to menstruation. High estradiol levels lead to increased FSH and LH levels, causing thickening of the endometrium. Estradiol and progesterone secreted by the corpus luteum allow for further development of the endometrium. Estradiol and progesterone also inhibit secretion of FSH and LH, preventing other follicles from developing. The menstrual cycle changes with age. Copyright first few years following menarche, irregular menstrual cycles, due to immaturity of the hypothalamic pituitary gonadal axis. Menstrual cycles are longest at 25 to 30 years of age, with younger and older individuals having shorter cycles. 4. Menstrual cycle changes. Cycle duration. Phases. Description. Mechanism. Histological changes. 2. From the first day of menses. C. During the secondary follicle stage, plus FSH stimulates the development of several follicles in the, to the day before the LH surge. Cuboidal granulosa cells continue to ovaries. Granulosa cells of follicles produce estrogen, accounts for most of the proliferate. Estrogen suppresses the release of FSH via negative, copyright 1-14 variability in the length of the multiple layers of thick granulosa cells. Follicular phase feedback loop, days menstrual cycle, surround an eccentrically located oocyte. Selection of a dominant follicle, Graafian follicle, follicle growth speeds up, most secondary follicles become atretic, positive feedback loop, high estrogen levels FSH release. But usually only one becomes a dominant LH surge ovulation follicle during the 2 week of this phase. Ovarian cycle 7Z. In ovulation, the Graafian follicle ruptures, releasing the asterisk during the tertiary follicle stage, the oocyte. Oocyte is surrounded by the corona radiata and asterisk. Following ovulation, the granulosa cells produce LH floats in follicular fluid. Degree i.e. asterisk from the day of the LH surge receptors. LH-induced transformation of the Graafian asterisk. The Graafian follicle moves to the surface. 45 A datal enhakatha hanin nina aftha nav. Back collapse. Fine text outline. Menstrual cycle changes. Cycle duration phases description mechanism histological changes too. From the first day of menses, FSH stimulates the development of several follicles during the secondary follicle stage, to the day before the LH surge. Cuboidal granulosa cells continue to ovaries. Granulosa cells of follicles produce estrogen. Scent accounts for most of the proliferate. Cis estrogen suppresses the release of FSH via negative, degree 1 to 14 variability in the length of the multiple layers of thick granulosa cells. Scent follicular phase feedback loop. Days menstrual cycle surround an eccentrically located oocyte. Selection of a dominant follicle, Graafian follicle. 1. Positive feedback loop, high estrogen levels. FSH release. LH surge. Ovulation. Follicle growth speeds up. Most secondary follicles become atretic during the 2 week of this, but usually only one becomes a dominant phase. Follicle. Ovarian cycle 7, in ovulation, the Graafian follicle ruptures, releasing the during the tertiary follicle stage. The oocyte is surrounded by the corona radiata and following ovulation. The granulosa cells produce LH floats in follicular fluid. From the day of the LH surge receptors. LH-induced transformation of the Graafian the Graafian follicle moves to the surface 15 cents luteal phase to the beginning of the next ES5 follicle into the corpus luteum. Progesterone production of the ovary, where it ruptures, and the days menses. Rennet, inhibition of LH release. Progesterone increase indicates secondary oocyte is released. The empty that ovulation has occurred. In tertiary follicle collapses. EFO pregnancy occurs, the corpus luteum regresses. 1 the corpus luteum atrophies. Absence of pregnancy. Resolution of corpus luteum contraction of spiral arteries in the stratum. A 9 cent menstrual bleeding occurs in progesterone concentration. Vasospasms in the uterine functionalis layer. Ischemia 23 plus Dave menses. This phase, usually 14 days. Spiral arteries bleeding. Degeneration of the functionalis layer. Y after ovulation. To actively delay menses, administer progesterone in the sloughing off of the functional layer of the second half of the menstrual cycle. 1 Endometrium. Scent proliferation of endometrial epithelial cells. Cells show high mitotic activity. Scent endometrial glands become straight, I tubular, and lined by simple columnar eye. Scent proliferative characterized by the growth of growing follicles produce estrogen. Granulosa cells express shell phase of the endometrium under the aromatase, which converts androgens to estrogens. Epihelum, days 2 RZ. Scent stromal cells start to divide, enlarge, and menstrual cycle influence of estrogens. Proliferation of the endometrium. Uterine accumulate glycogen. Cycle uterine spiral arteries start to regenerate and extend 2/3 of the way into the endometrium. Progesterone promotes endometrial differentiation. Preparation of the functional layer of the endometrium. 4_25 cents intracellular subnuclear vacuoles, a oocyte implantation. Scent the functional layer of the 7 increased endometrial gland tortuosity. 241 cervical mucus secretion, prevents spermatozoids from endometrium. Is prepared for 14 cents secretory phase entering uterus. Implantation under the days T. Basal body temperature. In the absence of pregnancy, progesterone levels. Apoptosis of the functional layer of the endometrium. Menstruation. Glycogen-rich secretions. Edematous stromal cells. Uterine spiral arteries extend the full length of the endometrium. Influence of progesterone. OO. FOT. Menstrual pain and cycle abnormalities. Menstrual cycle abnormalities include changes in the frequency and intensity of menstruation as well as symptoms such as pronounced abdominal discomfort, gastrointestinal complaints, and/or psychiatric symptoms. 7 CE. YS dysmenorrhea, menstrual pain. Primary dysmenorrhea. Scent definition. Recurrent lower abdominal pain shortly before or during menstruation, in the absence of pathologic findings that could account for those symptoms. Scent epidemiology. O prevalence up to 90%, most common gynecologic condition, 5. O manifests during adolescence, typically within 3 years of menarche. Scent etiology. Copyright. The etiology of primary dysmenorrhea is not completely understood. Copyright associated with some risk factors, example early menarche, nulliparity, smoking, obesity, positive family history. Scent pathophysiology, increased endometrial prostaglandin, PGF2 alpha, production leads to vasoconstriction/ischemia and stronger, sustained uterine contractions. 2. Back collapse. Find text outline. Scent pathophysiology, increased endometrial prostaglandin, PGF2 alpha, production leads to vasoconstriction/ischemia and stronger, sustained uterine contractions, to prevent blood loss. Asterisk clinical features 6. Copyright usually occurs during the first 1 to 3 days of menstruation. O spasmodic, crampy pain in the lower abdominal and/or pelvic midline, often radiating to the back or thighs. O headaches, diarrhea, fatigue, nausea, and flushing are common accompanying symptoms. O normal pelvic examination. Scent diagnostics. O primary dysmenorrhea is a diagnosis of exclusion. O rule out conditions that cause secondary dysmenorrhea, example endometriosis. Scent treatment. O symptomatic treatment, pain relief, example NSAIDs, topical application of heat. Copyright hormonal contraceptives, example combined oral contraceptive pill, IUD with progestogen. Secondary dysmenorrhea 5LL7. Scent definition, recurrent lower abdominal pain shortly before or during menstruation that is due to an underlying condition. Epidemiology. O may begin later in life than primary dysmenorrhea. O commonly affects female individuals. 25 years of age. Scent etiology. O uterine causes pelvic inflammatory disease, PID, intrauterine device, IUD, adenomyosis fibroids, intracavitary or intramural, cervical polyps. O extrauterine causes endometriosis adhesions functional ovarian cysts inflammatory bowel disease. Scent clinical features. O depend on the underlying cause. O secondary dysmenorrhea should be suspected in the following cases: onset, after 25 years of age. The pain tends to get worse over time. No previous history of pain with menstruation. Infertility, example adhesions, endometriosis, PID, irregular cycles. Abnormal uterine bleeding, example adenomyosis, fibroids, polyps, dyspareunia or postcoital bleeding. Partial or no response to therapy with NSAIDs and/or hormonal contraceptives. Scent diagnostics. O depend on the underlying cause. O initial laboratory testing CBC with differential, rules out infection, urinalysis, rules out UTIs. O other BHCG, rules out ectopic pregnancy, gonococcal/chlamydial swabs, rule out STDs and PID. Copyright pelvic ultrasound. Scent treatment, depends on the underlying cause. VA. OE. Amenorrhea, menstrual cessation. Primary amenorrhea 8LL9L. Abnormal pelvic examination, example uterine size, cervical motion tenderness, adnexal tenderness, masses, vaginal/cervical discharge. 5. Scent definition, the absence of menarche at 15 years of age despite normal development of secondary sexual characteristics, or absence of menses at 13 years of age in female individuals with no secondary sexual characteristics. Etiology. Causes of primary amenorrhea. Cause details. Constitutional * normal pubertal development, but adrenarche and gonad occur at a later age. Growth delay. GnRH, FSH and LH, estrogen and progesterone LLEJ, at the prepubertal level. Find text outline. Causes of primary amenorrhea. Cause details. GnRH, FSH and LH, estrogen and progesterone. Constitutional normal pubertal development, but adrenarche and gonad occur at a later age. Scent J, at the prepubertal level, growth delay. Asterisk caused by deficient release of GnRH asterisk examples hypogonadotropic E. Kallman syndrome, asterisk normal or J, hypogonadism copyright Prader-Willi syndrome copyright competitive sports, stress, eating disorders, copyright CNS tumors, example craniopharyngioma. Sent GnRH is released but the ovaries fail to produce estrogen and progesterone. Hypergonadotropic asterisk examples, gonadal dysgenesis 1-8-5b hypogonadism copyright 46, XY gonadal dysgenesis copyright Turner syndrome. Sent outflow tract obstruction with otherwise normal puberty examples. Anatomic anomalies degree Milidara cells sent normal plus normal copyright imperforate hymen copyright vaginal atresia copyright transverse vaginal septum. Examples copyright complete androgen insensitivity syndrome copyright 5-alpha reductase deficiency copyright congenital adrenal hyperplasia, CAH17-alpha hydroxylase deficiency. Receptor and enzyme abnormalities sent normal plus norma or T normal or. Sent clinical features, depend on the underlying cause sent diagnostics. O pregnancy test O check for secondary sexual characteristics and anatomical anomalies, physical examination, pelvic ultrasound. Equals uterus absent, perform karyotyping and serum testosterone to investigate for male/female genotype and androgen sensitivity. Equals uterus present, test FSH and LH levels. Exclude imperforate hymen, vaginal atresia, and transverse vaginal septum. Equals 1 FSH, primary ovarian insufficiency, example Turner syndrome, Swyer syndrome, premature ovarian failure, equals normal or JFSH, constitutional growth delay, hypogonadotropic hypogonadism copyright if galactorrhea is present, check prolactin and TSH levels. O if symptoms of hyperandrogenism are present, equals check serum testosterone and dehydroepiandrosterone sulfate, DHEAS. Equals if high, suspect an androgen secreting tumor. O if blood pressure is high, suspect congenital adrenal hyperplasia. Sent treatment O management of the underlying cause equals anatomical abnormalities, surgery equals hypogonadism, hormone replacement therapy with estrogens and progesterone O the goal of treatment is the progression of normal pubertal development. Secondary amenorrhea. Sent definition, the absence of menses for more than 3 months in individuals with previously regular cycles, or 6 months in individuals with previously irregular cycles. Sent etiology O pregnancy, most common cause of secondary amenorrhea ovarian disorders, example premature ovarian failure, polycystic ovary syndrome, medications, antipsychotics, chemotherapy, oral contraceptives, hypothyroidism, JT3/T4-TTTRHTF prolactin GnRHJ estrogens, hyperthyroidism, 1, hyperprolactinemia. Sheehan syndrome Asherman syndrome Cushing syndrome adrenal insufficiency obesity hypergonadotropic hypogonadotropic functional hypothalamic amenorrhea, a dysfunction in the pulsatile secretion of GnRH. Degree equals etiology equals excessive exercise, example in competitive athletes, also called exercise-induced amenorrhea, equals reduced calorie intake, example in eating disorders like anorexia nervosa, equals stress equals female athlete triad syndrome, menstrual dysfunction, calorie deficit, and decreased bone density in athletic female young adults or adolescents equals pathophysiology, decreased leptin, low body fat, and or increased cortisol, exercise/stress, plus decreased pulsatile release of GnRH from the hypothalamus, decreased secretion of FSH and LH, decreased estrogen levels, anovulation and secondary amenorrhea infertility. Sent clinical features, depend on the underlying cause. Sent diagnostics O pregnancy test. Back collapse fine text outline. Sent diagnostics O pregnancy test O if negative, obtain FSH, TSH, and prolactin levels. 1 FSH, ovarian insufficiency equals 1 TSH, hypothyroidism 7 prolactin equals recheck history for medication intake. Antipsychotics are the most frequent cause of medication-induced hyperprolactinemia. Equals perform brain MRI to evaluate for pituitary adenoma. O perform progestin challenge, 10 days of progestin intake, withdrawal bleeding induced, anovulation, example PCOS, idiopathic anovulation, premature ovarian failure, equals no withdrawal bleeding, may indicate uterine anomalies or estrogen deficiency. Test FSH levels. 1 FSH, hypergonadotropic hypogonadism or ovarian failure equals FSH, combined estrogen and progesterone challenge equals withdrawal bleeding induced, hypogonadotropic hypogonadism no withdrawal bleeding, endometrial or anatomical problem, example Asherman syndrome, equals if virilization is present, check testosterone, DHEAS, and 17-hydroxyprogesterone. Mild elevation, PCOS, congenital adrenal hyperplasia, Cushing syndrome. Equals moderate to high elevation, androgen-producing tumor scent treatment. O management of the underlying cause equals tumor surgical resection if possible equals prolactinoma, dopamine agonists, bromocriptine, cabergoline, equals functional hypothalamic amenorrhea. Lifestyle changes, reduce stress, improve nutrition, increase body weight, aim for BMI 19 kg/m. Equals offer pulsatile GnRH therapy or gonadotropin therapy to induce ovulation, 18LL9. Equals premature ovarian failure, combined oral contraceptives, OCPs, or hormone replacement therapy equals if trying to conceive, equals stimulation of ovulation with gonadotropin if failed, assisted reproductive technology equals treatment goals, prevent complications, example osteoporosis, heart disease, and maintain fertility. Physiological amenorrhea occurs before menarche, after menopause, during pregnancy, and during lactation. The female athlete triad of functional hypothalamic amenorrhea, low calorie intake/strenuous physical activity, low bone mineral density, and amenorrhea. Ovarian insufficiency. Scent definition, failure of adequate ovarian function, endocrine as well as reproductive, before the age of 40, which often leads to premature menopause. Primary ovarian insufficiency, POL, 1. Scent definition, ovarian insufficiency despite adequate gonadotropin stimulation, previously called premature ovarian failure, *etiology, 1, copyright idiopathic, 90% of cases, genetic disorders associated with ovarian hypoplasia, especially in women. Estrogen levels reduced feedback inhibition of estrogen on FSH and LH. TFFSH and LH, usually FSH-LH, 4 * clinical features, 12. Copyright climacteric symptoms such as vaginal dryness, night sweats, hot flashes, dyspareunia, and irritability. 1. Copyright abnormal/irregular bleeding pattern that can progress to secondary amenorrhea or permanent cessation of menstruation. Infertility or reduced fertility, pregnancy is possible via in vitro fertilization. Scent diagnostics copyright confirmed by 2 TFSH levels, 30 to 40 mlu/ml, and 2 estradiol levels, 3 months of menstrual irregularities in a woman under age 40. Further tests help determine the underlying cause, e.g., karyotyping, thyroid function. Scent treatment OC hormone replacement therapy. Copyright treatment of underlying causes. Secondary ovarian insufficiency. Scent definition, ovarian insufficiency due to inadequate stimulation of the ovaries by the hypothalamus and/or pituitary. See secondary hypogonadism. Back collapse. Find text outline. \abnormal uterine bleeding. See also endometrial cancer. Definition. Abnormal uterine bleeding, AUB, formerly known as dysfunctional uterine bleeding, is defined as menstrual bleeding that is abnormal and/or irregular in frequency, duration, and/or intensity. Sent it may or may not be accompanied by dysmenorrhea. Etiology 13. Sent the International Federation of Gynecology and Obstetrics, FIGO, has developed a classification, the POMCOIN system, to distinguish between structural and non-structural causes of abnormal uterine bleeding. 1. Sent structural causes, polyps, adenomyosis, leiomyomas, and malignancy and hyperplasia, POM. Sent non-structural causes, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not otherwise classified, COIN. Types, 114. Acute AUB, episodic uterine bleeding, in a non-pregnant female individual of reproductive age, that is of sufficient volume to require intervention to prevent further blood loss. Sent chronic AUB, uterine bleeding of abnormal frequency, regularity, and/or volume that has persisted for 6 months. Sent according to etiology degree AUBC, coagulopathies OAUBO, ovulation disorders, example disorders of the hypothalamic pituitary axis, PCOS, obesity. OAUBE, endometrial disorders EAUBI, iatrogenic causes, example estrogens, androgens, IUD, OAUBN, not otherwise classified, example uterine arteriovenous malformations, cesarean scar defect. Characteristics and causes of AUB according to FIGO, 15. Characteristic normal parameters, abnormal parameters, common causes. Absent, no bleeding, amenorrhea, see amenorrhea above. Pregnancy, including ectopic pregnancy, PCOS infrequent, cycles intervals 38 days, formerly known as insufficient caloric intake, example due to anorexia, oligomenorrhea, nervosa, hyperthyroidism, perimenopause. Frequency *224 to 38 days. Menarche, perimenopause, psychological stress. Frequent, cycles intervals. Sent irregular * variation between shortest and longest PCOS regularity cycle, 7 to 9 days, or normal cycle length plus copyright variation between shortest and longest cycle equals 8 to 10 days, the amount of variation considered normal. Sent perimenopause 4 days, 1 depends on the individual. Endometriosis duration *8 days, endometrial hyperplasia, endometrial cancer. Endometrial atrophy. Eating disorders, example anorexia nervosa, plus light menstruation, formerly known as hypomenorrhea, 7 Sent chronic endometritis. OCP use volume determined by the patient. Plus heavy menstrual bleeding, excessive blood loss. That endometrial cancer/hyperplasia interferes with physical, social, and/or emotional quality of endometriosis life. For hypothyroidism. Endometrial cancer/hyperplasia, cervical cancer *cervicities, random polyps, OCP use. Ovulation AA, sent breakthrough bleeding, mid-cycle bleeding due to hormone imbalance, usually after starting new OCP. Intermenstrual plus Novia 14 bleeding, therapy, C3 cyclic, predictable bleeding, minimal bleeding seen during copyright estrogen breakthrough 5 to 3 early, mid, or late cycle copyright progesterone breakthrough, copyright estrogen withdrawal 7. Endometriosis, myomas, polyps, carcinomas, contact bleeding, example during gynecological examination in patients with cervical carcinoma, during pregnancy, may indicate spontaneous abortion. Copyright. The most common causes of abnormal uterine bleeding, AUB, can be remembered by using the POMCOIN system: polyps, adenomyosis, leiomyomas, malignancy and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not otherwise classified. Diagnostics of AUB. Back collapse, fine text outline. Diagnostics of AUB. Sent gynecological history, age of menarche, last menstrual period, cycle length and regularity, pregnancies, family history, recent complaints or evaluation of possible causes guided by the POMCO-IN system. Copyright characteristics of abnormal bleeding, frequency, regularity, duration, volume, physical examination. Copyright if bleeding is acute, ensure the hemodynamic stability of the patient. Copyright pelvic examination, assess the severity and source of the bleeding, exclude structural abnormalities, neoplasms, and trauma. Copyright swabs for microbiologic testing, rule out cervicities due to gonorrhea/chlamydial infection. Pap smear, rules out cervical carcinoma. Sent initial laboratory testing. OCBC, rules out anemia. Copyright platelet count, PT, PTT, rule out bleeding disorders. Copyright BHCG, rules out pregnancy. Copyright additional testing if required, example thyroid function tests, prolactin, serum iron, plus pelvic ultrasound. 16. Copyright can be considered to rule out structural anomalies, example leiomyoma, adnexal mass. Copyright allows for evaluation of endometrial thickness. Endometrial biopsy, indications vary by age group and the presence of risk factors. Postmenopausal patients with any uterine bleeding and/or endometrial thickness equals 4 mm. 16. All patients 45 years of age with frequent, heavy, and/or prolonged bleeding. Patients. Non-surgical management. Sent general measures, immediate supportive measures in hemodynamically unstable patients such as fluid resuscitation, blood transfusion, and intrauterine tamponade, example intrauterine balloon, gauze packing, pharmacological. 17. Acute AUB in a hemodynamically stable patient. High dose for conjugated equine estrogen, equals alternatives, multi-dose regimens of OCPs or oral progestins, as well as tranexamic acid. Second line, copyright ovulatory bleeding equals OCPs, progestin, PO, for, or as. A levonorgestrel releasing IUD, equals NSAIDs, decrease blood loss, equals tranexamic acid. Anovulatory bleeding equals progestin PO for 10 days or as an IUD equals OCPs. Surgical treatment, 171. Sent indications. Severe bleeding/hemodynamic instability. Patient unresponsive to hormonal treatment. Co-hormonal treatment contraindicated, example breast cancer, endometrial cancer. Underlying medical condition requiring surgical repair. Sent procedures. Uterine dilation and curettage, D&C, with concomitant hysteroscopy equals diagnostic and therapeutic equals used to identify intrauterine pathologies, take tissue samples, and remove the excess uterine lining equals can decrease bleeding in less than an hour equals preserves fertility. Endometrial ablation equals only indicated if other treatments have been ineffective or are contraindicated equals provides long-term improvement of uterine bleeding symptoms by destroying a thin layer of the endometrium, example with extreme cold, heat, radiofrequency energy, equals hysteroscopy prior to ablation may be useful for identifying and treating intrauterine structural abnormalities, example polyps, fibroids. Equals contraindications include equals desire to have children, endometrial ablation does not preserve fertility. 7. Equals pregnancy equals endometrial hyperplasia or endometrial cancer equals history of transmyometrial uterine surgery. Copyright transcatheter uterine artery embolization equals recommended in the case of fibroids. First line therapy in patients with AUB due to uterine arteriovenous malformation, AVM, hysteroscopy, in case of endometrial polyps. Back collapse. Find text outline. Hysteroscopy, in case of endometrial polyps. Hysterectomy, reserved for patients who do not respond to any other treatment, no longer desire fertility, or have symptomatic anemia. Copyright in patients with acute abnormal uterine bleeding and onset of menarche within the last year. Anovulatory bleeding due to immaturity of the hypothalamic pituitary gonadal axis should be considered. OOE. Premenstrual syndrome, PMS. Sent epidemiology. Copyright occurs in up to 12% of female individuals. 81. Copyright age of onset, 20 to 30 years of age, 8 * clinical features. Degree LL80 onset of symptoms 5 days before menstruation. O pain, dyspareunia, breast tenderness, headache, back pain, abdominal pain. Copyright gastrointestinal changes, nausea, diarrhea, changes in appetite, food cravings, copyright bloating and weight gain. Copyright tendency to edema formation. Neurological, migraine, increased sensitivity to stimuli. O psychiatric, mood swings, drowsiness, lethargy, exhaustion, depression, anxiety, aggressiveness, social withdrawal. * diagnostics. Degree. Copyright diagnosis is based on history and self-assessment, example maintaining a PMS diary. Copyright pre-existing endocrine, example thyroid disorders, and psychiatric, example major depressive disorder, conditions should be ruled out. PMS versus PMDD. Premenstrual syndrome, PMS, premenstrual dysphoric disorder, PMDD, descent the onset of severe discomfort or functional impairment prior * severe affective symptoms and behavioral changes that cause clinically significant disturbance of daily definition to menstruation, life. Present in the 5 days prior to the beginning of menstruation. For * present up to 7 days prior to the onset of menstruation for the majority of cycles within 1 year. Diagnostic at least 3 consecutive cycles. * 25 symptoms that are marked and/or persistent, example depressed mood, anxiety, anger, affective lability, criteria sent end within 4 days after the beginning of menstruation. Sleep disturbances, change in appetite, pain, headache, interfere with normal daily life activities. Significant interference in daily life, work, home, social activities, interpersonal relationships. Plus treatment. 2019 lifestyle changes can be beneficial, example regular exercise, healthy diet, avoiding individual triggers like alcohol, caffeine, or nicotine. O first-line treatment equals NSAIDs, example naproxen, OCPs equals SSRIs, example fluoxetine. In the case of severe PMS and PMDD. O dietary supplements, reduce symptoms and improve mood swings equals calcium, 1200 mg per day, 9, equals vitamin E equals vitamin D equals. In the case of water retention / bloating, equals diuretics, example spironolactone, magnesium. On CG Sus. Mittelschmerz. Scent definition. Copyright physiological preovulatory pain in female individuals of reproductive age. Copyright also referred to as ovulatory or mid-cycle pain. Scent epidemiology, occurs in approximate 40% of female individuals of reproductive age. 21. Scent etiology, enlargement and rupture of the follicular cyst and contraction of fallopian tubes during mid-cycle ovulation lead to transient peritoneal irritation from follicular fluid. Scent clinical features. O recurrent unilateral lower abdominal pain, can mimic appendicitis, equals pain occurs during mid-cycle in individuals with regular menses. Dull and achy pain which can become cramp-like, equals can last up to 3 days. Copyright physical examination, lower abdominal pain on palpation, enlarged adnexa. Back collapse. Fine text outline. E-management, reassurance and symptomatic treatment with NSAIDs as needed. WA. OE. Differential diagnosis and treatment of dysmenorrhea and abnormal uterine bleeding. Condition. Primary dysmenorrhea. Endometriosis. Adenomyosis. Clinical features. Spasmodic, crampy pain in the lower abdominal and/or pelvic midline. 1. Chronic pelvic pain that worsens before the onset of menses. Dysmenorrhea, dyspareunia, infertility, dyschezia. Rectovaginal tenderness and palpable adnexal masses. Dysmenorrhea AUB, chronic pelvic pain, uniformly enlarged uterus. Lower abdominal / pelvic pain AUB, endometritis, scent fever, if peritonitis or pelvic abscesses develop, * infertility. Endometrial *AUB carcinomas/hyperplasia. Often asymptomatic AUB /pelvic pain deuterin rhea. Infertility, urinary tract or bowel symptoms, dyspareunia. Often asymptomatic plus AUB endometrial polyps. AO. Infertility/difficulty conceiving, incidental finding. Related 1-minute telegram. Is NTR of DY rhea and AUB. Diagnostics. Diagnosis of exclusion. Physical examination, erectovaginal tenderness, adnexal masses, transvaginal ultrasound, best initial test. Uterus usually not enlarged, copyright ovarian cysts, chocolate cysts. Laparoscopy or laparotomy, confirmatory test. MRI and transvaginal ultrasound can support the diagnosis and/or assist in ruling out other diagnoses, particularly leiomyoma, histopathology, only method that provides definitive diagnosis. Physical examination testing for typical pathogens, example chlamydia, endometrial biopsy, to evaluate chronic endometritis that is unrelated to pregnancy. Pelvic exam is often normal. Transvaginal ultrasonography, best initial test, abdominal ultrasonography, CXR, CT, MRI, to exclude metastases. B. Laboratory testing, to evaluate possible anemia and other causes of abnormal uterine bleeding, example coagulation disorders, endometrial biopsy with histology, definitive test to rule out endometrial cancer. Ultrasound, best initial test, MRI to evaluate surgical options and differential diagnoses. Transvaginal ultrasound, hysteroscopy, endometrial biopsy, rules out example endometrial hyperplasia, endometrial carcinoma. Sent 1-minute telegram 64-2022-3/3, COVID-19 related stress may cause menstrual irregularity. Sent diagnostics, pelvic ultrasound shows simple follicular cyst and small amount of intraperitoneal fluid. Treatments. Symptomatic, NSAIDs, topical heat hormonal contraceptives, example combined oral contraceptive pill, UD with progestogen. Pharmacologic degree combined OCPs, first line, copyright GnRH analogs, danazol, NSAIDs, progestin surgical. Copyright conservative, excision, cauterization, and ablation of lesions, copyright definitive, total abdominal hysterectomy/bilateral salpingo-oophorectomy, copyright removal of adhesions. Pharmacologic copyright NSAIDs, first line, copyright OCPs, progestin surgical, copyright conservative, hysteroscopy followed by endometrial ablation/resection, copyright definitive, hysterectomy. Mild to moderate cases, outpatient treatment, copyright 1 single dose of IM ceftriaxone and oral therapy with doxycycline, copyright addition of metronidazole should be considered in some cases, example patients who recently underwent gynecological procedures. Severe cases, inpatient treatment clindamycin plus gentamicin. Pharmacologic copyright progestins, in early stage endometrial carcinoma AE radiotherapy and/or chemotherapy surgical. Copyright abdominal hysterectomy with bilateral salpingo-oophorectomy - degree additional advanced radical hysterectomy and removal of the upper vagina, according to Wertheim Meigs, A. Treat only if symptomatic. Pharmacologic EOGnRH agonists, progestins, levonorgestrel releasing IUD androgenic agonists, example danazol, ENSAIDs, copyright antifibrinolytics. Interventional, uterine artery embolization surgical, copyright indications, rapidly growing fibroid, recurrent refractory bleeding, severe symptoms. EO procedures, MI or high Y, depends on the patient's preferences and their ability/desire to conceive in the future. Asymptomatic, observation and follow-up. Symptomatic, surgical removal. Interested in the newest medical research, distilled down to just 1 minute? Sign up for the 1-minute telegram in tips and links below. Back equals collapse. A. Find text. O. Outline. The menstrual cycle and menstrual cycle abnormalities, 1/4. Tropic hormones. Hypothalamus. Non-tropic hormones Y. Prolactin GHI. Copyright. Pituitary gland. Equals SD5. 5/8 ains. Equals mam ovaries / testis adrenal gland thyroid copyright. RM. S /I3BEE or mammary gland liver 2, FWN11WN1IOOII equals 1. 1 use I1IAA113BV. MK hormones cortisol *13, T4 lactation IGF-1. LU. Hypothalamic pituitary hormone axis VV. Corticotropin releasing hormone, CRH, thyrotropin releasing hormone, TRH, and gonadotropin releasing hormone, GnRH, are released from the hypothalamus, 1, into the portal vessels of the pituitary stalk, through which they reach the anterior pituitary gland, 2. The hypothalamic hormones then directly influence the release of adrenocorticotropic hormone, ACTH, thyroid-stimulating hormone, TSH, luteinizing hormone, LH, and follicle-stimulating hormone, FSH, from the anterior pituitary gland into the peripheral bloodstream. The pituitary hormones are distributed to their respective target organs, 3, where they regulate the release of glucocorticoids, adrenal gland, T3/T4, thyroid gland, estrogen, ovaries, and testosterone, testicles. Copyright Boss. The menstrual cycle and menstrual cycle abnormalities, 2/4. Ovulation follicular phase luteal phase. 1 cohort of tertiary follicle selection of dominant follicle Graafian follicle corpus hemorrhagicum corpus luteum corpus albicans LH. Estradiol. 2 FS. 3. Menstrual phase proliferative phase secretory phase. 4 bleeding. Variable period until ovulation 14 to 15 days after ovulation IT day 1 day 7 day 14 day 21 day 28. Menstrual cycle VV. The menstrual cycle consists of 2 phases, the follicular and the luteal phase. The onset of menses marks the beginning of the follicular phase, which usually lasts 12 to 14 days but may be variable. The luteal phase begins on the day of ovulation and lasts 14 days. During the follicular phase, FSH and LH stimulate the development of several follicles, one of which develops as the dominant follicle into the Graafian follicle. An LH surge initiates ovulation. As the oocyte reaches the fallopian tube, the ruptured follicle transforms into the corpus luteum, which produces progesterone. If no pregnancy occurs, the corpus luteum regresses and the progesterone level drops. This drop induces vasospasms in the uterine spiral arteries, ischemia, and sloughing off of the functional endometrial layer, which leads to menstrual bleeding, menstrual phase. During the proliferative phase, the endometrium is built up again in preparation for oocyte implantation during the secretory phase. 1. Stages of follicle development, 2. Hormone levels, 3. Phases of the endometrial cycle, 4. Development of the endometrium during the cycle. The menstrual cycle and menstrual cycle abnormalities, 3/4. Follicular phase early follicular phase. Hypothalamus. FSHS anterior pituitary gland. 3. Y. GAN-OO-pound and XA, WN, aromatase androgens AE estrogens A, in theca cells, in granulosa cells. on, ty. O. FSH receptors initial growth of HF, selection of dominant follicle multiple follicles. Female hypothalamic pituitary gonadal axis, 1/2. Copyright Boss. Middle follicular phase. Me androgens. FSH. J. Wang Seng. Os inhibin SAC at / aromatase PA _ estrogens J equals. TLH receptors, involution of non-dominant follicles, atresia. Late follicular phase and ovulation luteal phase. Hypothalamus. COOIFSHLHBX, RAQEFSHIE AMO copyright if Y. Postovulatory TV follicle a positive feedback * negative feedback S at high at low OO estrogen levels as corpus pound luteum and Phe Y degree. 2 / aromatase / 2 androgens estrogens progesterone estrogens AERAOT. Preovulatory LH, plus FSH, surge. Ovulation. Optimization of conditions for implantation. Female hypothalamic pituitary gonadal axis, 2/2, VV. Copyright Boss. X overview of common breast conditions. A number of conditions affect the breasts, including disorders of breast development, example congenital anomalies, breast hypertrophy, fibrocystic breast changes, inflammatory conditions, example mastitis, mammary ductal ectasia, benign neoplasms, example fibroadenoma, Phil-Lode's tumor, breast cancer, and breast cysts. Mastalgia is a common symptom that is often caused by an underlying benign etiology. This article provides a brief overview of common breast conditions. Each condition is detailed in the respective articles. See also palpable breast mass and nipple discharge. WA. OE. Benign neoplasms. Disorder. Fibroadenoma, LL2-LLS. Phil-Lode's tumor TATA. Inirasi wavelons. Lobular carcinoma in situ, LCIS, LEL 72829. Overview of benign neoplasms of the breast epidemiology clinical features. Solitary, well-defined, non-tender, rubbery, and mobile mass typically 1 to 2 cm in size generally do not increase in size. Most common breast mass in women. Painless, smooth, multinodular lump variable growth rate average size, 4 to 7 cm. Rare peak incidence, 40 to 50 years. Solitary lesions for copyright bloody or serous nipple discharge degree palpable breast tumor close to or behind the nipple or areola peak incidence, 30 to 50 years. Multiple lesions. EO usually asymptomatic. Approximate 85% of cases occur in premenopausal women. 7119, LCIS is a risk factor for invasive carcinoma. No specific findings, no mass or calcifications. Diagnostics. Ultrasound and / or mammography degree well-defined mass copyright popcorn-like calcifications may be seen. Confirmatory studies biopsy, fine needle aspiration, or excisional biopsy of fibers and glandular tissue. Ultrasound and / or mammography copyright well-defined solid mass that may contain cysts. Confirmatory studies, core needle biopsy or excisional biopsy copyright leaf-like architecture. Ultrasound and / or mammography 5 copyright well-defined mass within a dilated lactiferous duct. Confirmatory study, core needle biopsy 5 copyright papillary structure with fibrovascular core J. Usually an incidental biopsy finding, 9 * immunohistochemistry 9 degree E cadherin, negative copyright P120 catenin, diffuse cytoplasmic staining. Management. Expectant management or surgical excision, 3 lis. Surgical excision 2. No atypia, surveillance or surgical excision with atypia, surgical excision to rule out concomitant malignancy L. Asterisk expectant management, clinical and imaging follow-up I, surgical excision in select cases 1, breast cancer risk reduction options in select cases, chemoprevention, bilateral prophylactic mastectomy, ELT. Ad. Benign breast conditions most commonly affect women between the 3rd and 5th decades of life. WA. OS. Malignant neoplasms. Invasive ductal carcinoma. Invasive lobular carcinoma. Inflammatory breast cancer. Back. Overview of malignant neoplasms of the breast. Clinical features. Firm, fixed mass with irregular borders. Skin changes, example retraction, dimpling, thickening, axillary lymphadenopathy. Bloody nipple discharge. Rapidly growing breast mass. The breast mass degree TES, burning ion axillary lymphadenopathy. Erythematous and edematous, POD orange, skin plaques directly above. AEWN collapse. Breast imaging. Asterisk on ultrasound degree irregular mass copyright indistinct borders echogenicity, heterogeneous or hypochoy on mammography, or DBT. Copyright poorly defined margins degree spiculated margins degree clustered microcalcifications. A. Fine text. Biopsy. Malignant cells within the lactiferous duct stromal invasion microcalcifications fibrosis in surrounding tissue. Malignant cells in lobules monomorphic cells in a single file pattern. E. Non-circumscribed hyperdense mass dermal lymphatic invasion, angioinvasion. O. Outline. Invasive ductal carcinoma. Invasive lobular carcinoma. Inflammatory breast cancer. Paget disease of the breast. The breast mass. Cysts and fibrocystic changes. Disorder. Fibrocystic breast degree changes 10. Breast cysts/IL-17-18. Asterisk frequently occurs during. Galactosele degree. WA. OE. Epidemiology. Most common benign breast condition. Peak incidence, 35 to 50 years of age. Or after lactation. Most common benign breast lesion in lactating women. Benign inflammatory disorders. Epidemiology. Most common in nursing mothers. Mastitis. Back. Overview of malignant neoplasms of the breast. Clinical features. Firm, fixed mass with irregular borders. Skin changes, example retraction, dimpling, thickening, axillary lymphadenopathy. Bloody nipple discharge. Rapidly growing breast mass. Erythematous and edematous, POD orange, skin plaques directly above. Tenderness, burning sensation. Axillary lymphadenopathy. Breast imaging. Asterisk on ultrasound copyright irregular mass copyright indistinct borders echogenicity, heterogeneous or hypochoy. Asterisk on mammography, or DBT. Copyright poorly defined margins copyright spiculated margins degree clustered microcalcifications. Erythematous, scaly, or vesicular rash affecting the nipple and areola. Pruritus, burning sensation, nipple retraction. Possibly a firm, rigid mass with irregular borders. Overview of breast cysts and fibrocystic breast changes. Clinical features. Premenstrual breast tenderness. Multiple breast nodules bilaterally. Single or multiple breast masses. Variable size, microcysts, gross cyst, clusters, and texture, smooth, soft, firm, may be tender, usually mobile. Asterisk painless, firm subareolar mass 1. Diagnostics. Age-appropriate imaging of a palpable breast mass, ultrasound and/or mammography. I, degree distorted breast parenchyma, scattered coarse calcifications 1121. Copyright clustered microcysts, simple breast cysts, complicated breast cysts 1314, ISI, 7. Concern for malignancy, image-guided core needle biopsy 116. Ultrasound is preferred. IF6. Copyright simple breast cyst, copyright complicated breast cyst, copyright complex breast cyst. Concern for malignancy, see biopsy. Primarily a clinical diagnosis if 19. Imaging, ultrasound, 20. Copyright variable findings, copyright simple cyst with a fat fluid level is characteristic, fine needle aspiration, 1, milky ASPI rate 20. Overview of benign inflammatory disorders of the breast, clinical features. Asterisk tender, firm, swollen, erythematous breast, generally unilateral, flu-like symptoms. Diagnostics. Asterisk usually clinical, 22, sent if no response to empiric antibiotic therapy for mastitis, consider. Copyright breast milk cultures, 22. Biopsy. Duct stromal invasion, microcalcifications, fibrosis in surrounding tissue. Malignant cells in lobules, monomorphic cells in a single file pattern. Non-circumscribed hyperdense mass, dermal lymphatic invasion, angio-invasion. Paget cells. Management. Symptomatic management. Excision followed by close surveillance for breast cancer. Simple breast cysts, no intervention needed unless symptomatic. 3 complicated breast cysts, surveillance or biopsy F. Complex breast cysts, biopsy if 7 in 8. Copyright benign, surveillance OE malignant, surgical excision. Asymptomatic, usually resolves spontaneously. 21. Symptomatic, needle aspiration or drainage catheter placement, 22, infected, drainage and empiric antibiotic therapy for breast infections, 221 L19. Management. Puerperal mastitis, 22, 26, 27. Copyright supportive therapy, breastfeeding on demand, analgesics, cold compresses, copyright if no improvement after 12 to 24 hours of supportive therapy, empiric antibiotic. Malignant cells within the lactiferous. Reactive lymphadenopathy. Copyright biopsy 25. Equals. Collapse. Degree breast imaging 516 23 124, therapy for mastitis, example dicloxacillin, plus non-puerperal mastitis, initiate empiric antibiotic therapy for mastitis. Ifs, A. Find text. Al. Outline. Epidemiology. Scent most common in nursing, tender, firm, swollen, erythematous breast, generally unilateral. Overview of benign inflammatory disorders of the breast. Clinical features, diagnostics. Asterisk usually clinical, 22, plus if no response to empiric antibiotic therapy for mastitis, consider. Mastitis F. Mothers plus flu-like symptoms. Copyright breast milk cultures 22. Reactive lymphadenopathy. Copyright breast imaging A16 23-24. Copyright biopsy 25. Usually clinical asterisk breast pain, erythema, and edema asterisk breast ultrasound, 1223. Bensitibes asterisk commonly a complication plus fluctuant tender mass. Copyright irregular, hypochoy fluid-filled lesions A. Of puerperal mastitis 2 degree LL23 plus systemic signs, example fever, chills, copyright echogenic rim nausea, Copyright Posterior Acoustic Enhancement *FNAC and Culture of the ASPI rate. Sent breast ultrasound and/or mammography 2531 irregularly defined breast mass yen-GONSCE location degree alist fat necrosis sent often associated with soft 7p copyright coarse rim calcifications EAE kesoidina, sent skin retraction, erythema, and/or ecchymosis biopsy, 125. Most common in mammary duct perimenopausal women. Unilateral, non-milky gray, greenish, or bloody discharge sent nipple inversion. Copyright foam cells OE multinucleated giant cells. Breast ultrasound and/or mammography 32. Copyright dilated subareolar ducts. Biopsy if imaging findings are concerning for ectasia peak incidence, 40 to 55 NRAS sent firm, tender subareolar mass may malignancy 132 be present, copyright periductal inflammation copyright foamy histiocytes. Clinical diagnosis plus sudden onset age appropriate breast imaging should be mondor painful, thickened, cord-like lesion performed in all patients to exclude degree disease oft copyright rare, self-limited condition overlying irid. Of the SUI, 1134, TOE2 underlying malignancy veins of the breast and/or anterior chest wall copyright superficial tubular structure with a 7I beaded appearance. OOIOE. Mastalgia. Overview of mastalgia disorder epidemiology clinical features diagnostics. Cyclical mastalgia TINFS 235. Very common, especially in women 30 to 50 years of age, non-cyclical mastalgia 1122111351. 7. O'Haired N. Disorders of breast development. Disorder epidemiology. Congenital affect 1 to 6% of the general anomalies of the 36 breast population. Back. Sent unilateral or bilateral breast pain. Bilateral, diffuse breast pain, upper outer breast quadrant, usually worsens the week prior to the onset of menstruation. Imaging is not routinely required. C3. Management. Puerperal mastitis, 22 26 27 copyright supportive therapy, breastfeeding on demand, analgesics, cold compresses, copyright if no improvement after 12 to 24 hours of supportive therapy, empiric antibiotic therapy for mastitis, example dicloxacillin, non-puerperal mastitis, initiate empiric antibiotic. Therapy for mastitis. 28. Abscess drainage empiric antibiotics for breast infections 180 analgesics. Typically not needed 31-28. Usually not necessary 33 surgical duct excision for persistent symptoms or to rule out malignancy 182. Conservative measures. Copyright well-fitting bra copyright topical analgesics. Management. Identify and treat the underlying etiology. Sent initial, non-pharmacological measures, example well-fitting bra, and analgesics. Usually located over the costal cartilages sharp or burning pain and/or soreness. Breast imaging often indicated CA, see diagnostics in mastalgia for details. Overview of breast development disorders. Clinical features diagnostics. Amastia, absence of breast tissue and nipple scent polymastia, presence of accessory breast tissue scent athelia, absence of nipple scent polythelia, presence of accessory nipple scent Poland syndrome 137 clinical degree unilateral aplasia/hypoplasia of the pectoralis muscles and breast with associated finger abnormalities, example brachysyndactyly, WVNA collapse. A. Fine text. Moderate to severe or refractory symptoms, consider hormonal therapy, example danazol, tamoxifen. Management. Send surgical correction. O. Outline. Already cut TTT. Mondor. Disease oft plus rare, self-limited condition plus breast. OS. Mastalgia. Disorder epidemiology. Cyclical mastalgia, 11S235. Asterisk very common, especially in women 30 to 50 years of age, non-cyclical mastalgia, 1182-135. Sudden onset painful, thickened, cord-like lesion overlying erythema of the superficial veins of the breast and/or anterior chest wall. Degree foamy histiocytes. Asterisk clinical diagnosis asterisk age-appropriate breast imaging should be performed in all patients to exclude underlying malignancy. 1134. Copyright superficial tubular structure with a beaded appearance. Overview of mastalgia clinical features. Bilateral, diffuse breast pain, upper outer breast quadrant, usually worsens the week prior to the onset of menstruation. Unilateral or bilateral breast pain, usually located over the costal cartilages sharp or burning pain and/or soreness. Diagnostics. Imaging is not routinely required. A. Asterisk breast imaging often indicated. See diagnostics in mastalgia for details. Disorders of breast development. Disorder epidemiology. Congenital asterisk affect 1 to 6% of the general anomalies of the 36 breast A population. Breast hypertrophy 38 390 140 rare. Asterisk physiological gynecomastia, common in neonates, male res 41 dole, and men 50 years, 42-43 asterisk drug-induced gynecomastia, most common type of pathological gynecomastia. Age. FO, BOE. Tips and links. Sources. Back. Overview of breast development disorders. Clinical features diagnostics. Amastia, absence of breast tissue and nipples. Polymastia, presence of accessory breast tissue. Athalia, absence of nipples. Polythelia, presence of accessory nipples. Poland syndrome 371 * clinical. Copyright unilateral aplasia/hypoplasia of the pectoralis muscles and breast with associated finger abnormalities, example brachysyndactyly. Copyright most commonly develops on the right side. Enlarged breasts, symmetrical or asymmetrical, mastalgia muscular discomfort and/or pain in the neck, shoulder and/or upper back. Skin infections and erythema in intertriginous areas. Deep, painful brassiere strap grooving. Asterisk mainly clinical. Asterisk mainly clinical. Firm, concentric subareolar mass. Asterisk pathological may be tender. The underlying etiology. Last updated November 25, 2022. VA collapse. EY. Gynecomastia, evaluate for. Find text. Asterisk conservative measures. IW, degree well-fitting bra. Copyright topical analgesics. Management. Scent identify and treat the underlying etiology. Scent initial, non-pharmacological measures, example well-fitting bra, and analgesics. Asterisk moderate to severe or refractory symptoms, consider hormonal therapy, example danazol, tamoxifen. Management. Surgical correction. Surgery, reduction mammoplasty, standard of care, or bilateral total mastectomy, alternative, conservative, use of proper fitting, supportive bra. Medical therapy, progesterone or antiestrogen therapy, bromocriptine. Physiological gynecomastia, Reassurance pathological gynecomastia, treat the underlying cause. Persistent symptoms copyright medical therapy, off-label selective estrogen receptor modulators copyright surgery, subcutaneous mastectomy. Logi. Al. Outline. X. Vulvovaginitis. Vulvovaginitis refers to a large variety of conditions that result in inflammation of the vulva and vagina. The causes may be infectious, example bacterial vaginosis in most cases, or non-infectious. Physiologically, the normal vaginal flora, mainly lactobacilli, keeps the pH levels of the vaginal fluids low, thus preventing the overgrowth of pathogenic and opportunistic organisms. Disruption of that flora, example due to sexual intercourse, predisposes to infection and inflammation. Diagnosis of infectious vulvovaginitis is based on histology examination of vaginal discharge. Treatment consists of administration of antibiotics or antifungals, depending on the pathogen. For information on vulvovaginal atrophy caused by declining estrogen levels, see menopause. WA. OIEEE. Infectious vulvovaginitis. Etiology, 1. Common causes of infectious vulvovaginitis copyright bacterial vaginosis copyright vaginal yeast infection copyright trichomoniasis copyright aerobic vaginitis and other causes of infectious vulvovaginitis, see respective articles for more information, copyright enterobius vermicularis, especially in prepubescent girls, copyright scabies, 7-year itch, copyright pediculosis pubis, crabs, pubic lice. Differential diagnoses of infectious causes of vaginal discharge. Overview features bacterial Inocetrichiasis, vaginal yeast infection gonorrhea chlamydia infections Gardnerella law trichomonas. Path TGA Candida albicans Cent Neisseria gonorrhoeae chlamydia trachomatis serotype DKV. SA frothy, yellow-white, crumbly, and thick, cottage scent purulent, creamy scent purulent, bloody discharge green cheese like AE fishy odor A, scent foul smelling odorless scent may be malodorous. Vaginal inflammation typically absent scent present absent. Cervicities typically absent scent often present plus absent present. Vaginal pH copyright greater than 4.5 degree 4 to 4.5 variable. Gram negative, intracellular scent intracellular organisms that gram microscopy findings clue cells flagellated protozoa pseudohyphae. A. Diplococci stain poorly. Metronidazole topical azoles or nistidine azithromycin. IOI ceftriaxone 4/IMNTI. Treat sexual oral fluconazole in non-pregnant doxycycline in non-pregnant patients equals treat sexual partner, S, patients treat sexual partner, S. Copyright partner therapy is recommended in most cases of STDs, particularly chlamydia, trichomoniasis, and gonorrhea. Bacterial vaginosis and vaginal yeast infection do not require treatment of the partner, S. O. As. Bacterial vaginosis. Scent epidemiology, most common vaginal infection in women, 22 to 50% of all cases, ALT scent pathogen, Gardnerella vaginalis, a pleomorphic, gram-variable rod, 1 scent pathophysiology. Lower concentrations of Lactobacillus acidophilus lead to overgrowth of Gardnerella vaginalis and other anaerobes, without vaginal epithelial inflammation due to absent immune response. Scent risk factors copyright sexual intercourse, primary risk factor, but it is not considered an STD, O intrauterine devices. Back collapse find text outline. Risk factors copyright sexual intercourse, primary risk factor, but it is not considered an STD, intrauterine devices copyright vaginal douching O pregnancy. Degree. Scent clinical features copyright commonly asymptomatic copyright increased vaginal discharge, usually gray or milky with fishy odor, copyright pruritus and pain are uncommon. Scent diagnostics, diagnosis is confirmed if three of the following AMSEL criteria are met for copyright: clue cells, vaginal epithelial cells with a stippled appearance and fuzzy borders due to bacteria adhering to the cell surface. 1. Identified on a vaginal wet mount preparation. O vaginal pH 4.5 copyright positive amine test, sometimes referred to as the WIF test. The addition of 1 to 2 drops of 10% potassium hydroxide to a sample of infected vaginal discharge emits a characteristic amine odor. 5. Lel copyright thin, homogeneous gray-white or yellow discharge that adheres to the vaginal walls plus treatment. O asymptomatic, reassurance, often resolves without treatment. CIO symptomatic. First line in non-pregnant and pregnant patients. AFL equals oral metronidazole equals or intravaginal metronidazole equals or intravaginal clindamycin. Alternative in non-pregnant and pregnant patients. Oral clindamycin U1 * alternative in non-pregnant patients. Oral tinidazole or oral secnidazole 1I. Copyright treatment of sexual partner, S, is not recommended. Scent complications. O adverse pregnancy outcomes, preterm delivery, spontaneous abortion, postpartum endometritis. Copyright reinfection, consider retesting after 3 months. Q adaptive, AMSEL criteria, bacterial vaginosis, clue cells, discharge, gray or milky, electrons, pH of vaginal secretions is alkaline, fishy odor of discharge, and gestation, increased risk for miscarriage, are the most important features of bacterial vaginosis. Feedback. Manage. Vaginal yeast infection, vulvovaginal candidiasis. Epidemiology, second most common cause of vulvovaginitis, 17 to 39% of all cases. 2. Pathophysiology, overgrowth of C. albicans. Copyright can be precipitated by the following risk factors: pregnancy immunodeficiency, both systemic, example diabetes mellitus, HIV, immunosuppression, and local, example topical corticosteroids, antimicrobial treatment, example after systemic antibiotic treatment. 1 plus clinical features: O white, crumbly, and sticky vaginal discharge that may appear like cottage cheese and is typically odorless. Mo erythematous vulva and vagina. OE. Vaginal burning sensation, strong pruritus, dysuria, dyspareunia. * diagnostics. 7. O pseudohyphae on a vaginal wet mount with potassium hydroxide, KOH. 1 copyright vaginal pH within normal range, 4 to 4.5, treatment. O non-pregnant patients, topical azole, example miconazole, clotrimazole, or single-dose oral fluconazole. Degree pregnant patients, 7-day course of a topical azole, example miconazole, clotrimazole. 6. Oral fluconazole is not recommended for use in pregnant patients because of a possible association with spontaneous abortions and fetal malformations. HH == Back collapse. Fine text outline. Trichomoniasis. Scent epidemiology, for 35% of all cases. 2 scent pathogen, Trichomonas vaginalis e anaerobic, modal protozoan with flagella. Copyright does not insist and, therefore, does not survive well outside the human body. 8. Scent transmission, sexual scent. Clinical features: O foul-smelling, frothy, yellow-green, purulent discharge. Copyright vulvovaginal pruritus, burning sensation, dyspareunia, dysuria, strawberry cervix, erythematous mucosa with petechiae. AA*. Diagnostics, IL degree. O saline vaginal wet mount. Initial test: modal trophozoites with multiple flagella. PM = if the wet mount is inconclusive, perform a culture or nucleic acid amplification testing. NAAT. 1 copyright pH of vaginal discharge 4.5. Copyright routine screening in asymptomatic, non-pregnant and pregnant patients is not recommended. Treatment 1 copyright first line in non-pregnant and pregnant patients, Oral metronidazole degree alternative in HIV-negative non-pregnant patients. Oral tinidazole copyright concurrent treatment of sexual partner, S. Equals female sexual partners, same as treatment for the primary patient. Equals male sexual partners, single-dose oral metronidazole, alternative, single-dose oral tinidazole, copyright check for other sexually transmitted infections. Scent complications, adverse pregnancy outcomes, example preterm delivery, intrauterine growth restriction. After sex, burn the foul, green tree burning sensation and foul smelling, yellow-green discharge are the features of trichomoniasis. FAEMD. GA, A2. SA equals. EEDE. OEGS your note. Of OPCSCW wines rar fu shared notes Viana. Non-infectious vulvovaginitis. Differential diagonal of iginities features inary SY of allergic vulvovaginitis, mechanical vulvovaginitis, low estrogen levels, pruritus and itching, example due to atopic dermatitis, psoriasis, etiology ** atrophy of epithelium in vagina and vulva, as well as atrophy of the * contact allergy, psychosomatic conditions, urethra and bladder scent friction. * decreasing labial fat pad * typically prepubescent * typically postmenopausal women potentially with a history of lichen vaginal soreness, dryness, girls sclerosis, clinical * dyspareunia * signs of inflammation, scent pruritus, features urinary symptoms, scent pruritus, scent signs of inflammation, receding pubic hair, scent burning sensation, urinary symptoms and / or dyspareunia. Diagnostics * clinical diagnosis, allergy diagnostics * dermatological and / or rheumatological workup. Avoid irritants, moisturizers and lubricants, treatment local or systemic estrogen therapy. See also treatment of GSM. Scent moisturizers and cause-specific cooling, scent cortisone creams, moisturizers and cooling. GYUR. OSO. Allergic vulvovaginitis. Scent epidemiology, may affect all age groups, but are especially common in prepubescent girls. Scent etiology, allergies to laundry or cleaning detergents, textile fibers, sanitary napkins, etc. Scent clinical features, pruritus, redness, swelling, burning sensation. Scent diagnostics, special allergy diagnostics, example prick/puncture, intradermal test, may be indicated if symptoms persist despite treatment. Scent treatment copyright avoid irritants copyright soothing lotions, ice packs, and sitz baths, example containing chamomile. Back collapse fine text outline. Scent treatment copyright avoid irritants copyright soothing lotions, ice packs, and sitz baths, example containing chamomile, copyright cortisone creams if needed. Mechanical vulvovaginitis. Scent etiology copyright pruritus, example due to atopic dermatitis, psoriasis, psychosomatic conditions, copyright friction of tight clothes, obesity. Women suffering from postmenopausal estrogen deficiency or lichen sclerosis are especially at high risk. Scent clinical features, pruritus, redness, swelling, sometimes dysuria, and / or dyspareunia. Scent diagnostics, special dermatological or rheumatological tests to find the cause of pruritus. Scent treatment depends on the cause. Copyright soothing lotions / creams, ice packs, and sitz baths, example containing chamomile. WA. CE. Special patient groups. Vulvovaginitis in pediatric patients. Scent epidemiology, most common gynecological disorder in prepubertal children. Scent etiology poor hygiene, most common cause, copyright foreign body in the genitourinary tract. 15 use of perfumed soaps and bubble baths. Copyright localized skin disorders. In some cases, sexual abuse. Scent pathophysiology, estrogen levels are lower in prepubescent girls, making the vulvar skin and vaginal mucosa very thin. This makes them more susceptible to vulvovaginitis of any cause. Scent clinical features copyright vaginal discharge, often bloody, purulent, or foul-smelling copyright pain in the lower abdomen and suprapubic region copyright increased urinary frequency, burning during urination, and dysuria copyright in some cases, visible segment of a foreign body at the genital opening scent diagnostics. If an infectious etiology is suspected, then appropriate gram stain, culture, PrEP, DNA PCR, etc. should be conducted. Direct visualization of the foreign body, either on physical examination or by means of pelvic ultrasonography, plain pelvic radiography, vaginography, or MRI. Scent treatment. In the case of foreign body, removal of foreign body. First line of treatment, warm saline irrigation of the vagina in an outpatient setting. 4 equals if irrigation fails, removal under general anesthesia. Antibiotics/antifungals are usually not needed if successful removal is achieved, as the vulvovaginitis would then spontaneously resolve. Copyright topical or oral antibiotics/antifungals. Copyright conservative measures, improving hygiene, avoidance of tight clothing. Infectious vulvovaginitis in pregnant patients. Scent etiology, infections with the same pathogens of STDs as non-pregnant patients. Scent clinical features depending on the pathogen, example itching, vaginal discharge, increased risk of adverse pregnancy outcomes, spontaneous abortion, premature rupture of membranes, chorioamnionitis, neonatal infection, postpartum endometritis. Scent diagnostics. Asymptomatic, pregnant patients equals no recommendation for screening for bacterial vaginosis, trichomoniasis, and genital herpes virus infection. Equals recommended screening for other STDs, example HIV, syphilis, hepatitis B, hepatitis C, chlamydia. Eosymptomatic, pregnant patients, same diagnostic studies as for non-pregnant patients. See infectious vulvovaginitis above and management of sexually transmitted infections in Sexually Transmitted Infections article. Scent treatment. Copyright targeted treatment according to the pathogen. Copyright careful evaluation of whether a drug is safe to use during pregnancy. Back collapse. Fine text outline. Urovulvovaginitis, 1/1. Bacterial vaginosis, mainly Gardnerella vaginalis, LE. _A, 4. Gray or milky discharge. Trichomoniasis, Trichomonas vaginalis, strawberry cervix. Yellow-green, frothy discharge. A. Yeast infection, mainly Candida albicans. TM. Thick, white, curd-like discharge, cottage cheese appearance, Kex fishy odor. Positive amine test, whip test, elevated pH, 4.5, G. Clue cells. Copyright, foul-smelling elevated pH, 4.5. Flagellated protozoa. Differential diagnosis of infectious vulvovaginitis. Copyright Boss. Normal pH, 4.0 to 4.5, EAWF \n pseudo-hyphae. Clue cells in bacterial vaginosis VV. Photomicrograph of a vaginal smear specimen, vaginal wet mount, medium power magnification, squamous cells with a stippled appearance and fuzzy borders can be seen, clue cells, due to bacteria adhering to the cell surface. The presence of clue cells is one of the 4 EMSL criteria, besides thin, white, yellow, homogeneous discharge, vaginal fluid pH of 4.5, and a fishy odor after adding 10% potassium hydroxide solution to wet mount, for the diagnosis of bacterial vaginosis. Gardnerella vaginalis is the most common cause of this condition. Source, ID #3720, CDC/MRAIN, Centers for Disease Control and Prevention licensed under public domain. Urovulvovaginitis, 3/3. Bacterial vaginosis, mainly Gardnerella vaginalis, LE. _A, 4. Gray or milky discharge. Trichomoniasis, Trichomonas vaginalis, strawberry cervix. Yellow-green, frothy discharge. A. Yeast infection, mainly Candida albicans. TM. Thick, white, curd-like discharge, cottage cheese appearance, Kex fishy odor positive amine test, whip test, elevated pH, 4.5, G. Clue cells. Copyright, foul-smelling elevated pH, 4.5. Flagellated protozoa. Differential diagnosis of infectious vulvovaginitis. Copyright Emposs. Normal pH, 4.0 to 4.5, EAWF/N pseudo-hyphae. Candidal vulvovaginitis. Vaginal cavity of a woman presenting with vaginal pruritus and white odorless vaginal discharge. White, cottage cheese-like discharge can be seen adhering loosely to the vaginal walls, which have patchy areas of inflammation. Source, speculum_exam_ in Candidal vulvovaginitis by Mikhail Hajstra 6M, Wikimedia Commons, licensed under CC by 1.0. Registered plus OO plus SF4 FAOESE A asterisk cent 0 asterisk E asterisk A 7 4M RAO ARE O overlay 4 pseudo-hyphae in vulvovaginal candidiasis. Vaginal wet mount after potassium hydroxide, KOH, preparation, microscopy, that shows Candida albicans forming multiple pseudo-hyphae, thin filamentous structures, examples indicated by blue overlay. The prominent gray and white circles are optical artifacts. White circles, examples of budding yeast. Source, Vaginal wet mount in Candidal vulvovaginitis.jpg by Mikhail Hajstra 6M, Wikimedia Commons, licensed under CC 1.0. Overlay. Pseudo-hyphae in vulvovaginal candidiasis. Vaginal wet mount after potassium hydroxide, KOH, preparation, microscopy, that shows Candida albicans forming multiple pseudo-hyphae, thin filamentous structures, examples indicated by blue overlay. The prominent gray and white circles are optical artifacts. White circles, examples of budding yeast. Source, Vaginal wet mount in Candidal vulvovaginitis.jpg by Mikhail Hajstra 6M, Wikimedia Commons, licensed under CC 1.0. Urovulvovaginitis, 3/3. Bacterial vaginosis, mainly Gardnerella vaginalis, LE. _A, 4. Gray or milky discharge. Trichomoniasis, Trichomonas vaginalis, strawberry cervix. Yellow-green, frothy discharge. A. Yeast infection, mainly Candida albicans. TM. Thick, white, curd-like discharge, cottage cheese appearance, Kex fishy odor positive amine test, whip test, elevated pH, 4.5, G. Clue cells. Copyright, foul-smelling elevated pH, 4.5. Flagellated protozoa. Differential diagnosis of infectious vulvovaginitis. Copyright Emposs. Normal pH, 4.0 to 4.5, EAWF/N pseudo-hyphae. Urovulvovaginitis, 1/4. Copyright overlay. Trichomonas vaginalis VV phase contrast photomicrograph of vaginal discharge, high magnification. These parasites with flagella, blue overlay, are Trichomonas vaginalis, the causative pathogen of trichomonal vaginitis. In the center, 2 squamous epithelial cells can be seen. Source, ID #5238, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Overlay. Strawberry cervix and sandy patches. Colposcopy image of the ectocervix in a patient with trichomoniasis and schistosomiasis co-infection. The ectocervical mucosa is diffusely erythematous and multiple well-defined punctate hemorrhages, examples indicated by arrowheads, are visible. Strawberry cervix. This finding is characteristic of trichomoniasis. There are also clusters of small, sandy-colored lesions, sandy patches, examples indicated by yellow overlay, which are consistent with schistosomiasis, schistosoma hematobium. Dashed line, squamocolumnar junction source, Fig 24, in the colposcopic atlas of schistosomiasis in the lower female genital tract based on studies in Malawi, Zimbabwe, Madagascar, and South Africa by Norsitham, and Lovia P.D., Klepai, et al., Pilos Nigeltro dis, licensed under CC by 4.0. Modifications, dashed line removed. Urovulvovaginitis, 2/4. Overlay. Strawberry cervix and sandy patches. Colposcopy image of the ectocervix in a patient with trichomoniasis and schistosomiasis co-infection. The ectocervical mucosa is diffusely erythematous and multiple well-defined punctate hemorrhages, examples indicated by arrowheads, are visible. Strawberry cervix. This finding is characteristic of trichomoniasis. There are also clusters of small, sandy-colored lesions, sandy patches, examples indicated by yellow overlay, which are consistent with schistosomiasis, schistosoma hematobium. Dashed line, squamocolumnar junction source, Fig 24, in the colposcopic atlas of schistosomiasis in the lower female genital tract based on studies in Malawi, Zimbabwe, Madagascar, and South Africa by Norsitham, and Lovia P.D., Klepai, et al., Pilos Nigeltro dis, licensed under CC by 4.0. Modifications, dashed line removed. Urovulvovaginitis, 3/4. Trichomonas vaginalis. Photomicrograph of Trichomonas vaginalis trophozoites, Guiam stain, high magnification, the protozoan appears oval-shaped with flagella, examples indicated by arrowheads, and a nucleus, green overlay, located at the anterior end. Source, Figure 3, in Prevalence of Trichomonas vaginalis among females visiting some selected hospitals in Makurdi, Benue State, Nigeria by I. Marsuan, OMNYNWO, International Journal of Microbiology and Biotechnology, licensed under CC by 4.0. Urovulvovaginitis, 4/4. Bacterial vaginosis, mainly Gardnerella vaginalis, LE. _A, 4. Gray or milky discharge. Trichomoniasis, Trichomonas vaginalis, strawberry cervix. Yellow-green, frothy discharge. A. Yeast infection, mainly Candida albicans. TM. Thick, white, curd-like discharge, cottage cheese appearance, Kex fishy odor. Positive amine test, WIP test, elevated pH, 4.5, G. cells. Copyright, foul-smelling elevated pH, 4.5. Flagellated protozoa. Differential diagnosis of infectious vulvovaginitis. Copyright Boss. Normal pH, 4.0 to 4.5, EAWF/N pseudo-hyphae. X. Polycystic ovary syndrome. Polycystic ovary syndrome, PCOS, is one of the most common endocrine disorders in women. It is characterized by hyperandrogenism, which primarily manifests as hirsutism, acne, and, occasionally, virilization, algovulation/anovulation, and/or the presence of polycystic ovaries. The diagnosis involves a complete history and physical examination to evaluate for ovulatory dysfunction and clinical signs of hyperandrogenism. Laboratory tests are performed to confirm biochemical hyperandrogenism and exclude other conditions with a potentially similar clinical picture, example congenital adrenal hyperplasia. Ultrasound may be performed in adults to identify cystic follicles and assess ovarian volume but is not required for diagnosis if ovulatory dysfunction and hyperandrogenism are present. Management consists of lifestyle modifications combined with specific treatment, which is tailored to the patient's reproductive goals. In women who do not wish to conceive, combined oral contraceptive pills are indicated to regulate menses and treat hyperandrogenism. For women who wish to conceive, the goal of treatment is to induce ovulation, example with letrozole. Women with PCOS are twice as likely to develop metabolic syndrome, which is associated with obesity, insulin resistance, hypercholesterolemia, and an increased risk of endometrial cancer. Therefore, all patients should be screened for comorbidities and receive specific treatment for these when necessary. OOE. Epidemiology. SENT prevalence, 6 to 12% of women in their reproductive years in the U.S. Epidemiological data refers to the U.S., unless otherwise specified. O and pathophysiology. Asterisk, the exact pathophysiology is unknown. 1. Strong association with obesity. 1. In peripheral estrogen synthesis from adipose tissue and J. In peripheral sensitivity to insulin. 2. SENT reduced insulin sensitivity, peripheral insulin resistance, and the consequent hyperinsulinemia result in O. Epidermal hyperplasia and hyperpigmentation, acanthosis nigricans. 8. E1 androgen production in ovarian theca interna cells. Imbalance between androgen precursors and the resulting estrogen produced in granulosa cells. 1. LH secretion disrupts the LH/FSH balance. Impaired follicle maturation with cyst formation due to lack of follicle rupture and anovulation/algovulation. Infertility. 1. Androgen precursor release and T estrogen production in adipose tissue. 4. O. Inhibition of SHBG in the liver. T free androgens and estrogens equals 1. Unopposed estrogen, lack of progesterone, during anovulatory cycles. Endometrial hyperplasia. T risk of endometrial carcinoma. 6. Hyperandrogenism in women is most commonly caused by PCOS. 006, FOT. Clinical features. Onset of symptoms typically occurs during adolescence. SENT menstrual irregularities. O. Primary or secondary amenorrhea. Copyright oligamenorrhea. Copyright menorrhagia. O. Infertility or difficulties conceiving. SENT insulin resistance and associated conditions. O. Metabolic syndrome, especially obesity. 1. Risk of sleep apnea. Copyright non-alcoholic fatty liver disease. Back collapse. Fine text outline. SENT skin conditions. Copyright hirsutism. E. Androgenic alopecia. Copyright acne vulgaris. Copyright oily skin. E. Acanthosis nigricans. SENT psychiatric conditions. Copyright depression. O. Anxiety disorders. Copyright voice change may occur in severe forms of PCOS. However, it typically suggests a different underlying cause of hyperandrogenism. FO and pathology. Macroscopic appearance. Plus multiple, brown cysts arranged in a circular pattern in the subcapsular region of the ovary. Trademark SENT cysts are relatively small and of approximately the same size. Microscopic appearance. SENT ovarian hypertrophy with thick capsule. SENT stromal hyperplasia and fibrosis. SENT multiple enlarged cystic follicles. MS. SENT hyperluteinized theca cells. Decreased granulosa cell layer. Differential diagnoses. Hyperandrogenism. 51. Overview. SENT definition, a state of excess androgen levels that causes symptoms such as growth of facial hair, deepening of the voice, and male pattern baldness. SENT. For more information about physiological causes of hyperandrogenism, see pregnancy. Differential diagnosis of hipism in female. I. Incidence. Onset. Characteristic finding plus most common, 75 to 80% of 7FF PCOS. Asterisk parapubertal. Asterisk polycystic ovaries on pelvic ultrasound cases. Non-classic CAH parapubertal. 17-hydroxyprogesterone. CAH** congenital ambiguous genitalia * common Cushing disease * anytime. 24-hour urine-free cortisol hypothyroidism sent anytime TTSH. Hyperprolactinemia * anytime 1 colon G hand prolactin androgen secreting tumor, E.9, Sexmzeavael * primarily affects women 30 to 40 years of age 1 colon DHEAS, 700J1G/DL, tumor, adrenal, uncommon 3 decade of life, mean age at diagnosis usually 40 to 45 years, acromegaly cent TIGF127 NIS. Back collapse fine text outline. *A** bilateral increase in ovarian stroma on pelvic ovarian hyperthecosis * rare * perimenopausal or postmenopausal ultrasound. Scent affected individuals, congenital * ambiguous external genitalia pi7 on E rare me scent maternal, during pregnancy * 1 testosterone and estrogen drug induced, example sotasteroid jandrogen, JJ, *N/A+1 testosterone or DHEA. Clinical features of hyperandrogenism. Scent virilization, the appearance of male secondary sexual characteristics in a female individual. Hirsutism, excessive male pattern hair growth, example chin, upper lip, midsternum, abdomen, back, buttocks. Male pattern hair loss. Acne. Increased muscle mass. Voice deepening. Copyright clitomegaly scent. Rapid onset of virilization is suggestive of exogenous androgen intake or androgen secreting tumors. Scent manifestations of the underlying condition. Diagnostics of hyperandrogenism. Scent laboratory tests to identify hyperandrogenemia. 1 serum total testosterone. SHBG. Free androgen index. Scent investigate for the underlying cause. Treatment. Scent medication to suppress or block androgen and manage symptoms of virilization. OCPO anti-androgen drugs, example spironolactone, finasteride. Scent treat the underlying cause, example surgery for androgen secreting tumors. The differential diagnoses listed here are not exhaustive. OOH-FU-R. Diagnostics. Rotterdam Criteria 6L91-101. PCOS is diagnosed in adults based on the presence of at least 2 of the following criteria, after other endocrinological conditions, example thyroid disease, hyperprolactinemia, have been excluded. Scent algovulation and/or anovulation. Scent hyperandrogenism, based on clinical features or laboratory studies. Examine patients for signs of acne, alopecia, and hirsutism, obtain laboratory studies as needed. 6. Enlarged and/or polycystic ovary on ultrasound. Copyright ovarian volume 2 10 ml and/or the presence of multiple cystic follicles measuring 2 to 9 mm, string of pearls appearance, in one or both ovaries. 19. Laboratory studies, 6LL9I10. Scent confirm hyperandrogenism, obtain in all women with clinical features of PCOS, even if features are minimal or unclear. CA10O for testosterone, use the calculated free testosterone, calculated bioavailable testosterone, or free androgen index. Direct free testosterone has poor sensitivity. 10. Copyright androstenedione and TFD-hydroepiandrosterone sulfate. Scent rule out differential diagnoses, example pregnancy, endocrine disorders. Copyright a clinical picture of hyperandrogenism fulfills a diagnostic criterion of PCOS, even if serum androgen levels are normal. Copyright an elevated LH, with LH-FSH ratio 2:1, is a characteristic finding in most patients with PCOS but not necessary for diagnosis. Back collapse fine text outline. CG, identification of cystic follicles is not mandatory to diagnose PCOS. Evaluate for comorbidities, 0LL6LL9. Patients with PCOS are at risk of serious comorbidities, even at a young age. It is important to screen for these at the first visit and at regular intervals. Metabolic screening and monitoring. Measure weight, height, and waist circumference, calculate BMI. For patients with elevated BMI, obtain a fasting lipid profile and screen for symptoms of obstructive sleep apnea. 1. Copyright check blood pressure dash. Copyright assess glycemic status. 1. Scent mental health and quality of life, screen for anxiety, depression, and psychosexual dysfunction. WA. CE. Treatment. Approach, ALL9LL8. Recommendations for all patients. Encourage exercise and healthy eating, e.g. caloric restriction, and consider behavioral strategies and modifications, example setting goals, eating more slowly. 6L7. Target BMI. Patients not planning to conceive, 0L9I8. For patients who do not wish to conceive, the therapeutic goals are to control menstrual irregularities and hyperandrogenism, treat comorbidities, and improve quality of life. Scent combined oral contraceptives, COX, 8, copyright indication, first-line treatment for hyperandrogenism and / or menstrual cycle abnormalities. Copyright additional benefits. Endometrial hyperplasia. Risk of endometrial carcinoma, 11, menstrual bleeding. Acne treatment of hirsutism, 211L10. Scent metformin, improves menstrual irregularities, metabolic outcomes, and weight, especially when combined with lifestyle modifications, plus antiandrogens. Controversial role, 1. Examples, spironolactone, finasteride, flutamide. Indications, can be considered for treatment of hirsutism and androgen-related alopecia in patients unable to take or tolerate COX. Copyright additional recommendation, when using antiandrogens as an alternative to COX, it is advisable to use other forms of contraception. Scent additional interventions, other measures, like anti-obesity medications or bariatric surgery, may be considered on a case-by-case basis. Patients planning to conceive, ALL9. The goals of treatment for patients who wish to conceive are management of comorbidities, example weight loss for overweight or obese patients, and induction of ovulation. Scent letrozole, first-line therapy for ovulation induction. Improves pregnancy and live birth rates in patients with anovulatory infertility with no other causes. Mechanism of action, aromatase inhibition reduces estrogen production, stimulating FSH secretion and inducing ovulation. Scent clomiphene, alternative to letrozole. May be preferred over metformin monotherapy in obese women with anovulatory infertility. 10. Copyright mechanism of action, inhibits hypothalamic estrogen receptors. Disruption of the negative feedback mechanism governing estrogen production. 7. Pulsatile secretion of GnRH7 FSH and LH. Stimulation of ovulation. Exogenous gonadotropins. The low-dose regimen is the second-line treatment for ovulation induction. Agents, exogenous FSH and human menopausal gonadotropin. Copyright indication, typically used if first-line therapies are unsuccessful, occasionally used as first-line if the drug and monitoring requirements are accessible. 10. Metformin can be used as second-line monotherapy for fertility treatment. Copyright combination with clomiphene may increase pregnancy rates, especially in obese women. Copyright first-line therapy for insulin resistance. 8. Scent additional fertility interventions. Laparoscopic ovarian drilling. Back collapse. Fine text outline. Combined oral contraceptives, COX, 8. Copyright indication, first-line treatment for hyperandrogenism and / or menstrual cycle abnormalities. 1. Copyright additional benefits. Endometrial hyperplasia. Risk of endometrial carcinoma. 11. Menstrual bleeding. Acne treatment of hirsutism. 211I10. Scent metformin, improves menstrual irregularities, metabolic outcomes, and weight, especially when combined with lifestyle modifications, plus antiandrogens. Controversial role, 1. Examples, spironolactone, finasteride, flutamide. Copyright indications, can be considered for treatment of hirsutism and androgen-related alopecia in patients unable to take or tolerate COX. Copyright additional recommendation: when using anti-androgens as an alternative to COX, it is advisable to use other forms of contraception. Scent additional interventions, other measures, like anti-obesity medications or bariatric surgery, may be considered on a case-by-case basis. Patients planning to conceive, 1009. The goals of treatment for patients who wish to conceive are management of comorbidities, example weight loss for overweight or obese patients, and induction of ovulation. Scent letrozole, first-line therapy for ovulation induction. Improves pregnancy and live birth rates in patients with anovulatory infertility with no other causes. Mechanism of action: aromatase inhibition reduces estrogen production, stimulating FSH secretion and inducing ovulation. Scent clomiphene, alternative to letrozole. 1 Copyright may be preferred over metformin monotherapy in obese women with anovulatory infertility. 10 Mechanism of action: inhibits hypothalamic estrogen receptors. Disruption of the negative feedback mechanism governing estrogen production. 7 Pulsatile secretion of GnRH, FSH and LH. Stimulation of ovulation. Exogenous gonadotropins. The low-dose regimen is the second-line treatment for ovulation induction. Agents: exogenous FSH and human menopausal gonadotropin. Copyright indication: typically used if first-line therapies are unsuccessful, occasionally used as first-line if the drug and monitoring requirements are accessible. 10. Scent metformin O can be used as second-line monotherapy for fertility treatment. 111 Copyright combination with clomiphene may increase pregnancy rates, especially in obese women. Copyright first-line therapy for insulin resistance. 8 Scent additional fertility interventions. Laparoscopic ovarian drilling equals a laparoscopic procedure in which ovarian tissue is reduced with a laser beam or surgical needle to decrease its volume and androgen production equals. This hormonal shift can induce FSH secretion and improve ovarian function in patients with polycystic ovary syndrome. Second-line treatment for ovulation induction can be performed as a first-line treatment if other indications for laparoscopy exist. Copyright in vitro fertilization can be offered as third-line therapy. Management of other PCOS manifestations. 8 Copyright hirsutism, non-pharmacological therapy is first-line, example electrolysis, light-based hair removal via laser or photoepilation. Copyright acne, consider topical therapies, example benzoyl peroxide, topical antibiotics. Complications: Scent cardiovascular disease. Scent type 2 diabetes mellitus plus malignancy, increased risk before menopause. 50 Endometrial cancer. Copyright ovarian cancer. Copyright pancreatic cancer. Kidney cancer. Endocrine cancers, except thyroid. Pregnancy loss. We list the most important complications. The selection is not exhaustive. Road. Sources: last updated September 6, 2023. Back collapse. Fine text outline. Polycystic ovary syndrome, PCOS, hair thinning, alopecia. Etiology unknown associated with insulin resistance and obesity. Depression, anxiety disorders. Diagnostics: Rotterdam criteria. Ovulation or anovulation. Hyperandrogenism. Hirsutism. Degree. Clinical features: acne, alopecia, hirsutism, or acne. Laboratory features: T. testosterone, enlarged and/or polycystic ovaries on non-alcoholic ultrasound examination. Fatty liver disease. Acarithos negaceans. Treatment: weight loss, obesity, hyperglycemia, metabolic syndrome. No wish to conceive. Degree. Combined oral contraceptives, 1 *line, metformin, 2 Scent line, wish to conceive. Degree. Ovulation induction, 1 *line, letrozole, infertility, menstrual irregularities, complications, polycystic ovary, cardiovascular disease, type 2 diabetes mellitus, malignancy, example endometrial cancer, pregnancy loss. Polycystic ovary syndrome, PCOS, Fact Sheet V. Copyright Boss. 4 GnRH pulsatility. Thika, plus,
제가 혼자
granulosa
살면서 하고
cells
싶은
y
거 다
interna
하고
cells
사는
if
때문에
peripheral
나름
arrest of
착실하게
insulin and
설득을 하고
FT
있는데요. 제
insulin
목표는
dash
20대 안에
T
1억을 모으는
androgens
거예요. 저는 저를 꾸미는
TLH
것도
slash
좋아하고
FSH
꾸미는 것도
follicular
좋아하고 취미도 너무 많고
resistance
또 저는 화살
maturation
가득한 인스타충이기 때문에 게임이나
LJLJC
호캉스도 너무
T
좋아하고 그래서 일단
estrogens
핸드폰은 5년째 갤럭시 쓰고 있고 근데도
Pathophysiology of
당연히 LG
polycystic
제품이나
ovary
가구 같은 건
syndrome
거의
yet
다 당근에서 구하고
in
전세가 저렴한
polycystic
아주
ovary
오래된
syndrome
주택을 구해서 셀프로
PCOS
인테리어했습니다.
peripheral insulin resistance example
여행이나
due to
호캉스는
obesity causes hyperinsulinemia. Hyperinsulinemia stimulates androgen production in cells of the ovarian theca interna. Levels of free androgens are further increased by reduced sex hormone binding globulin, SHBG, production in the liver. Hyperandrogenemia stimulates LH release from the anterior pituitary gland, resulting in a disruption of LH/FSH balance and, consequently, impaired follicle maturation. LH/FSH balance is further impaired by increased GnRH pulsatility in the hypothalamus and the conversion of androgens to estrogen in adipose tissue. Copyright Boss. Polycystic ovary syndrome, 1/2. Overlay. Polycystic ovary syndrome, PCOS, Stein-Leventhal syndrome, VB. Macroscopic specimen of an ovary, transverse section, there are multiple, circularly arranged, brown subcapsular cysts, examples indicated by green overlay, on the subcapsular region, which are relatively small and of approximate the same size. This is the typical appearance of a polycystic ovary, see illustration for a schematic representation. In addition to the abnormal changes observed here, the ovary is frequently enlarged and as a result there is an increase in stromal tissue. Source, copyright IMPP. Polycystic ovary syndrome, 1/2. Overlay. Polycystic ovary syndrome, PCOS, Stein-Leventhal syndrome, VB. Macroscopic specimen of an ovary, transverse section, there are multiple, circularly arranged, brown subcapsular cysts, examples indicated by green overlay, on the subcapsular region, which are relatively small and of approximate the same size. This is the typical appearance of a polycystic ovary, see illustration for a schematic representation. In addition to the abnormal changes observed here, the ovary is frequently enlarged and as a result there is an increase in stromal tissue. Source, copyright IMPP. Polycystic ovary syndrome, 2/2. Polycystic ovary syndrome, PCOS, Stein-Leventhal syndrome, VB. H&E stain of a follicular cyst, the inner lining consists of granulosa cells, which are arranged in several uniform layers. Theca. Internal and theca external cells, which are surrounded by stroma, can be seen behind them. Source, copyright IMPP. IC5SH/OB. 5.4 cm/13 Hz routine Harneder. PWR 100% GN9C8/M5P3/E1. Overlay. Polycystic ovary syndrome VB. Transvaginal ultrasound of the right and left ovary, both ovaries contain multiple anechoic, subcapsular cysts with a string of pearls appearance, shaded in green, and posterior acoustic enhancement, green arrows. There is a relative increase of stromal tissue and capsule thickness with increased ovarian size, marked in green. This is a typical finding in polycystic ovary syndrome. Copyright Boss. IC5SH/OB. 5.4 cm/13 Hz routine Harneder. PWR 100 GN9C8/M5 number 3/E1. Overlay. Polycystic ovary syndrome VV. Transvaginal ultrasound of the right and left ovary, both ovaries contain multiple anechoic, subcapsular cysts with a string of pearls appearance, shaded in green, and posterior acoustic enhancement, green arrows. There is a relative increase of stromal tissue and capsule thickness with increased ovarian size, marked in green. This is a typical finding in polycystic ovary syndrome. Copyright Boss. IC5SH/OBMI 1.24.2 cm/27 Hz TIS 0.1 routine 9.00 to 2.00 PWR 100% GN1C8/M5 POE41. Overlay. Polycystic ovary syndrome (VV). Transvaginal ultrasound image of a patient with polycystic ovary syndrome. The green areas denote multiple anechoic cysts, 15 cysts, within the ovary, and both stromal tissue and capsule are increased in size. Copyright Emboss. IC5SH/OB 1.2 cm/27 Hz routine 9.00 to 2.00 PWR 100 GN1C8/M5 PG/E41. Overlay. Polycystic ovary syndrome (VV). Transvaginal ultrasound image of a patient with polycystic ovary syndrome. The green areas denote multiple anechoic cysts, 15 cysts, within the ovary, and both stromal tissue and capsule are increased in size. Copyright Emboss. X. Pelvic inflammatory disease. Pelvic inflammatory disease, PID, is caused by a bacterial infection that spreads beyond the cervix to infect the upper female reproductive tract, uterus, fallopian tubes, ovaries, and surrounding tissues. The most common pathogens that cause PID are Chlamydia trachomatis and Neisseria gonorrhoeae. Patients may be asymptomatic, have mild pelvic pain with vaginal discharge, or present with signs of systemic inflammation, including fever and severe abdominal pain. PID is a clinical diagnosis. Asymptomatic patients might only be diagnosed retrospectively during a workup for complications such as infertility. Initial diagnostic studies include evaluation for STIs and pregnancy. Atypical or severe presentations and/or suspected complications may be confirmed with imaging and, in rare cases, laparoscopy. Empiric antibiotic therapy that covers both Chlamydia trachomatis and Neisseria gonorrhoeae is indicated when the minimum criteria for PID are met, even if no specific infectious cause is identified. PID can cause scarring that may lead to long-term complications, including infertility, ectopic pregnancy, and chronic pelvic pain. GoAED Neospes. Definition. Scent: a bacterial infection that spreads beyond the cervix to the upper female reproductive tract and/or peritoneal cavity, causing any of the following: Jo endometrium, endometritis, see also postpartum endometritis degree fallopian tubes, salpingitis, pyosalpinx, tubo-ovarian abscess, copyright ovaries, oophoritis, tubo-ovarian abscess, E surrounding pelvic structures, parametritis, copyright pelvic peritoneum, peritonitis. OORI. Epidemiology. Lifetime prevalence, 4.5% in women of reproductive age, 18 to 44 years.
Disseminated
Greater than 1
intravascular
million women
coagulation,
experience
DIC,
an episode of PID/year. 2% PID is one of the most common causes of infertility. 1 epidemiological data refers to the U.S., unless otherwise specified. OOOE. Etiology. Plus pathogens/LL4LO most common, Chlamydia trachomatis, Neisseria gonorrhoeae O less common. Consider co-infections E. coli, ureaplasma, mycoplasma, and other anaerobes plus risk factors. 4O multiple sexual partners, unprotected sex, copyright history of prior STIs and/or adnexatus O intrauterine devices. 5 Copyright risk is lower during pregnancy. PID development during pregnancy increases the risk of maternal morbidity and preterm births. 5 Copyright vaginal dysbiosis 1, 6. Clinical features. Lower abdominal pain, generally bilateral, which may progress to acute abdomen M7 nausea, vomiting, fever, dysuria, urinary urgency, menorrhagia, metrorrhagia, dyspareunia, abnormal vaginal discharge, yellow/green color. Back collapse, fine text outline. Diagnostics. PID is a clinical diagnosis. Copyright maintain a low threshold for assessing for PID in young, sexually active women with lower abdominal pain. Diagnostic criteria 8. Diagnostic criteria for PID 8 findings * any of the following in a sexually active female individual with pelvic pain or lower abdominal pain, in the absence of an alternative cause. See differential diagnoses. Minimum criteria for PID: copyright cervical motion tenderness, severe pain elicited by manipulation or movement of the cervix. Copyright uterine tenderness, degree adnexal tenderness. Any of the following additional criteria: copyright oral temperature 38.3 degrees Celsius 101 degrees Fahrenheit. Supportive criteria for PID: OMI PP, cervical discharge and/or cervical friability, example easily induced endocervical bleeding. Copyright abundant WBCs on microscopy of vaginal secretions. Copyright elevated ESR and/or CRP. Copyright confirmed cervical infection with N. gonorrhoeae or C. trichomonas A. Initial evaluation for PID 8IL9. Laboratory studies. Scent vaginal and/or cervical swab testing. Copyright NAAT and/or culture for N. gonorrhoeae and C. trichomonas. Scent pregnancy test, to rule out intrauterine and ectopic pregnancy. Scent blood tests. OHIV testing, RPR for syphilis. Copyright infection markers, nonspecific for PID. TRNO equals leukocytosis on CBC equals elevated ESR and/or CRP. Antigyam sustain of discharge typically shows cytoplasmic inclusions in C. trichomonas infection, but not in N. gonorrhoeae infection. A. Additional evaluation for PID 8IL9I10. Indications. Scent unclear diagnosis or concern for alternative diagnosis. 10 Scent severe illness, example nausea, vomiting, fever 38.5 degrees Celsius 101 degrees Fahrenheit. Scent lack of improvement. Imaging. Plus modalities: 1. Copyright transvaginal ultrasound. Copyright CT or MRI abdomen/pelvis E findings. Copyright free pelvic fluid. Copyright thickened fluid-filled fallopian tubes, due to salpingitis. 78L121. Copyright complications of salpingitis, e.g., equals pyosalpinx, the accumulation of pus in the fallopian tubes. 13 equals tubo-ovarian abscess equals perihepatitis. Ad. Imaging is not routinely indicated but can help confirm the diagnosis of PID, especially in ambiguous cases. Is. Back collapse. Find text outline. Invasive diagnostics. These methods can definitively confirm a diagnosis of PID, but are rarely used. Scent diagnostic laparoscopy O may show signs of tubal edema, erythema, and purulent exudate. Scent endometrial biopsy. O used to diagnose endometritis. Differential diagnoses. Common causes of lower abdominal pain in women of reproductive age. Disorder. Clinical features. Diagnostic clues. Therapy. Lower unilateral abdominal pain and guarding Basintia tegnanetes. Ectopic vaginal bleeding. Prega methotrexate or surgical removal. Pregnancy ultrasound, echogenic mass plus amenorrhea. Scent lower bilateral abdominal pain. Degree fever * cervical discharge _ PID. Antibiotics. Scent menorrhagia and metrorrhagia. Copyright CMT plus dyspareunia. * initially diffuse epigastric pain. Scent later localized right lower quadrant pain. * McBurney's point tenderness. Appendicitis equals * appendectomy. Nausea and vomiting. Fever ultrasound, appendiceal diameter of 6 mm. Unilateral colicky. Flank pain. Hematuria pain may radiate to the lower abdomen and ultrasound. Urinary tract obstruction and radiolucent genital area. Stones. Kidney stones. Destruction or removal of stone. Sudden onset unilateral lower abdominal pain. EES at deus netegrosixis gene. Exercise, ultrasound, adnexal mass and fluid in the pelvis, most ovarian cystopiny, commonly in the rectuterine pouch, rupture. Sexual intercourse. Laparoscopy/laparotomy to obtain hemostasis. EEA, negative pregnancy test. Minimal vaginal bleeding, spotting, can occur. equals equals. Continued surveillance or emergency exploratory. Sudden onset unilateral lower abdominal ultrasound with Doppler, enlarged, edematous ovary and / or pelvic pain with decreased blood flow ovarian torsion * emergency exploratory laparoscopy, adnexal detorsion copyright nausea and vomiting MRI abdomen and pelvis with contrast, twisted vascular NSNEAEA, adnexal mass may be palpable. Pedicle, whirlpool sign. Degree fever. 2. Medical history, recent gynecological surgery or adrenal pulmonary panic procedure infections, example cervicitis, endometritis, pelvic cellulitis ICIBOD14 fullness. Antibiotics ultrasound, hyperemic, edematous tissue surrounding the uterus absence of gastrointestinal and / or urinary signs, masses, or peritoneal signs. PID may manifest with symptoms of appendicitis due to periappendicitis or perihepatitis. Symptoms may also mimic ectopic pregnancy. The differential diagnoses listed here are not exhaustive. GO-U. OE. Treatment. Assess for risk factors necessitating inpatient management and admit if any of the following are present. Degree concern for surgical emergency, example differential diagnosis of acute abdomen, copyright tubo-ovarian abscess or severe illness with nausea, vomiting, fever 38.5 degrees Celsius 101 degrees Fahrenheit, and / or an unwell appearance degree pregnancy 10 unable to tolerate or adhere to an oral regimen. Empiric antibiotic therapy for PID. Inpatient management L degree L. Initiate prompt empiric parenteral antibiotics. O preferred, cephalosporin, cefotedin or cefoxidin, plus doxycycline O add metronidazole if a cephalosporin other than cefotedin or cefoxidin is used. After 24 to 48 hours of improvement, switch to an appropriate oral antibiotic regimen prior to discharge, example doxycycline plus metronidazole. Back collapse find text outline. O unable to tolerate or adhere to an oral regimen empiric antibiotic therapy for PID. Inpatient management / and LL9L. E initiate prompt empiric parenteral antibiotics. Copyright preferred, cephalosporin, cefotedin or cefoxidin, plus doxycycline O add metronidazole if a cephalosporin other than cefotedin or cefoxidin is used. After 24 to 48 hours of improvement, switch to an appropriate oral antibiotic regimen prior to discharge, example doxycycline plus metronidazole. Outpatient management at if there are no indications for inpatient management, most patients can receive outpatient treatment with a single dose of either of the following, equals IM ceftriaxone equals IM cefoxidin plus oral probenecid O followed by 14 days of oral doxycycline plus metronidazole. WA. 2. Complications. Short-term complications. Pelvic peritonitis Fitzhugh-Curtis syndrome, perihepatitis, O inflammation of the liver capsule, O characterized by violin string-like adhesions extending from the peritoneum to the liver. Tubo-ovarian abscess 8-215-216. Definition, an infectious inflammatory mass of the fallopian tubes and / or ovary that may spread to adjacent organs, example bladder, bowel. Diagnostics copyright imaging, most commonly ultrasound, is required to confirm the diagnosis. Treatment copyright at least 24 hours for 4 empiric antibiotic therapy for PID. Transition clinically improved patients to oral therapy with equals doxycycline equals plus either metronidazole or clindamycin long-term complications too. Pathophysiology, inflammation, example salpingitis, copyright tubal scarring O adhesions of the fallopian tubes and ovaries copyright hydrosalpinx, the accumulation of fluid in the fallopian tubes 13 manifestations copyright tubal infertility, related to loss of tubal ciliary function, ectopic pregnancy. Copyright chronic pelvic pain. We list the most important complications. The selection is not exhaustive. THOTES EIS. Tips and links. Sources. Last updated February 9, 2024. Back collapse. Find text outline. Uropelvic inflammatory disease, 1/1. Vaginal discharge in gonococcal infection VV. Purulent discharge can be seen on this patient's vulva on external genital examination. Source, SOA-Gonoro female by SOA AIDS Amsterdam, Wikimedia Commons, licensed under CC by SA 3.0. Cervical discharge in gonorrhea, speculum view, VV. The surface of the cervix is covered with yellowish-white, purulent discharge. The external OS of the uterus is inflamed and red. These findings are consistent with gonorrhea. Source, ID #4087, CDC, Centers for Disease Control and Prevention, CDC, licensed under public domain. Uropelvic inflammatory disease, 2 halves. Chlamydia trachomatis in McCoy cell culture VV. Photomicrograph of cells in McCoy cell culture, unknown magnification, cells infected with Chlamydia trachomatis, black arrows, show inclusion bodies, reticulate bodies, here in brown, under the microscope. Chlamydia are obligate intracellular bacteria that require cell culture, rather than growth medium, to grow. This characteristic is especially important for determining the best antibiotic for treatment. Source, ID #6428, CDC/Drive E. Aram, Drive N. Jacobs, Centers for Disease Control and Prevention, CDC, licensed under public domain. Pelvic inflammatory disease, 1/1. Copyright overlay. Fitzhugh-Curtis syndrome, perihepatitis, VV. Photograph of the caudal view of the upper right peritoneum during a laparoscopy. Fibrous adhesions, green overlay, are visible between the peritoneal surface, P, and the liver, L. No other pathological findings are seen. These adhesions are a characteristic complication of the liver capsule inflammation that occurs in Fitzhugh-Curtis syndrome. Source, copyright IMPP.